part of elevating the standard of care in UAE, and also for the physicians who will have been for a long journey actually participating with us, and also for all payers, clinical pharmacists, and also all of the attendees who will be with us today. So without further notice, let me move forward with our agenda for today. So actually we are going to start with Dr. Mohammed Farghali. He's the head of the DHA regulators, and also he was going to give us an overview of the RA epidemiology in the Middle East and in UAE. Then we'll move forward with the first session with Dr. Athir Al-Ansari, who is going to give us mainly the key variants and in remissions and what are the current elevation in standard of care. Moving forward with a very interesting data that has been taking so much time and preparation from Dr. Jamal. He's going to share it, which will be moderated also by our guest today, Professor Lieven Annemans. He's a health economist from Ghent University. So moving forward, we'll have the coffee break, and then a very interesting session also that we get feedback globally by Professor Lieven Annemans on the new therapies and the value of the innovative therapies beyond the price. Finally, then we'll have the current challenges in achieving remission. This will be a very interesting panel discussion, which will be moderated by Dr. Mustafa and also Dr. Babna and Dr. Himera Bacha, which will join us shortly in this meeting. And also Dr. Farghali will have a very interesting mandate that he's going to share during this session. After the lunch, Dr. Khaled Al-Naqbi will share with us actually the evolution and the recent managements and the recent options on treatment options available in rheumatoid arthritis, with the new classes available for now, forward by the major concepts of health economics for non-health economists, which will be delivered also by Professor Lieven Annemans. Then we are going to have a parallel workshop where we're going to have actually mainly the physicians. They are going to have a live broadcast from US with a psychiatrist, which will deliver a talk on how to change patient behaviors. It will be an interactive session. And the clinical pharmacist with our colleague from the market access, Mohammed Namira, is going to deliver a very interesting session about also the budget impact models. Finally, we'll close by the remission and resource utilization globally by Professor Lieven Annemans. And the most important and the core and the objective of our meeting today, which will be the consensus and the voting, which we need all of you to be here today, where we are going to ask you to vote on the standard of care and the updated core standard of care that we can move forward and what are the current needs. So without further notice, I'd like to introduce Dr. Mohammed Farghali for his first session.
Thank you very much. It's my pleasure to be with you here today morning. And I'm not a rheumatologist, but family physicians with background of diabetes and diabetologist. My second hat is I'm the consultant and advisor of health insurance in Dubai. Today you hear many times from our colleagues regarding the standards of care. Standards of care is the way in which we develop the guidelines, disseminating the guidelines for both payers and providers in Dubai. So once the guideline is published and it is announced and uploaded to our website, it is the way that each providers and payers have to follow, especially in Dubai. Our authority is only in Dubai. So we worked on rheumatoid arthritis with many group of you led by Dr. Jamal, and we reached to the guidelines which we published before. Now we work with other colleagues to develop the remission criteria and the delay in referral cases. We again talking about the privilege of prescribing, who's supposed to prescribe the biologics. We know that there is a lot of delay till you see yourself the patients when they are referred from primary health care. So that's why we should have a standard which will be followed by everyone, and it will be obligatory for the insurance to follow as long as it is coming from the expert and approved by the regulation and the executive office. I have the task today to share with you the overview of rheumatoid arthritis in the Middle East. I'm talking to rheumatologists who know better than me, but the epidemiological and the treatment pattern of rheumatoid arthritis in a large cohort of Arab patients, and this is done in 5 countries, and around 900 patients are recruited from different countries. We know that rheumatoid arthritis is a chronic autoimmune inflammatory disease. The prevalence of rheumatoid arthritis in North Europe and North America between 0.5 to 1%, and this number is going to increase. We know that the split of this low prevention of rheumatoid arthritis is ranked as we have high prevalence, but again, it is number 42 in disability globally. Other determinants of rheumatoid arthritis include the age, socioeconomic status, and ethnicity. A recent global burden study estimated rheumatoid arthritis prevalence in MENA region. It is 0.16, so it is very low prevalence, but we need again to aggressively treat the patients so we have remission early, and we will talk about this from the technical point of view by our consultant rheumatologist. Based on limited evidence from several MENA regions, we usually don't have data. If we have data, we have the power to change everything. I think our doctors, they have the data. Dr. Jamal have the data which he will share with us. They give me to develop the data of private sector, but actually I was very busy last week, so I didn't share any data, but I promise next meeting I'm sharing with you all the data related to rheumatoid arthritis in the private sector in Dubai. DMARDs are the mainstay treatment for rheumatoid arthritis prescribed to relieve joint pain, swelling, and to reduce disability, activity, and disability. Newer biologic agents are promising, and again, they have they support very much the treatment and the outcome, but we have a problem with the price and the cost. Again, we developed the mandate, which I'll share it with you, that for enhanced plan, there is no problem to prescribe the biologic, but if you are talking about the basic benefit plan or low salary bands, it is indicated if there is medical necessity. So if there is medical necessity and proper documentation and the reporting about the patient who should receive this medication, again, we have a mandate which approves this to be used. So to describe the demographic characteristic and the clinical profile and treatment patterns of patients of Arab with rheumatoid arthritis, this is the 5 countries, UAE, Saudi Arabia, Qatar, Lebanon, and Jordan, shows the demographic characteristic, clinical profile, and the treatment pattern are changed between the 5 countries. So we can see here the percentage of ever use of steroids and methotrexate. You will find in whole countries, in general, it's more than 80%, and the highest will be in Saudi Arabia and Jordan. The lowest will be in Emirates regarding the methotrexate and the steroids again. You will see here the discrepancy between ages in prescribing, and again there is over prescribing of methotrexate and the steroid. So the strength of this study is largest study of rheumatoid arthritis point in the Middle East. Study fill major gaps of rheumatoid arthritis epidemiology and characteristic pertaining to rheumatoid arthritis of Arab countries in the Middle East. The novelty of this study lays in the description, investigation, and comparison of medication pattern between 5 nations of different GDP and level in the Eastern Mediterranean region. The limitation of this study is there is a bias inheritance of cross-sectional analysis of the convention sample of the convenience sample. The prevalence of comorbidities and the medication use could be underestimated due to recall bias, as the information could be missing from the patient medical records. Records were not maintained for eligible patients who refused to participate. Thus, the characteristic of those who refused the participation could not be evaluated there was a lack of central lab test of anti-CCP and RF to ensure the accuracy of these results, and the missing data of anti-CCP and rheumatoid factor status precluded a complete clinical assessment of rheumatoid arthritis in the study population. The conclusion of this study, there is disparities in usage of rheumatoid arthritis treatment among Arab patients, and are not across the 5 countries. There is discrepancy between the 5 countries. National GDP as well as some other unique features in each country likely affect these, and developing treatment guideline specific to this region could contribute to deliver standard therapies of rheumatoid arthritis. This is what we have to agree upon. Once we agree, it will be distributed, disseminated to providers and payers, and published in our website. Different studies in different areas, the need for tightness of rheumatoid arthritis in South African, and the functional disability and the health-related quality of life in South Africa with rheumatoid arthritis patient. Again, in Morocco, the health-related quality of life, and this with low level of education and socioeconomic status, had significantly lower health-related quality of life score than in general population. Patients who receive methotrexate and biologic drugs exhibit better score for mental health. Low health-related quality of life was significantly correlated with the disease duration, joint pain intensity, clinical and biological disease. This all studied from Morocco, and then you will have the socioeconomic impact of rheumatoid arthritis again in Morocco. Other significant adverse impact due to rheumatoid arthritis include the divorce, the sexual problems, the problems in performing domestic chores, and the participated in leisure activity. Again, from Egypt, you have studies in 2010 found increase in cardiovascular risk in group with rheumatoid arthritis, and this was particularly in the presence of smoking, obesity, and other risk factors. 2012 found a high prevalence of sexual dysfunction among both females and males, and this disorder was significantly related with cardiovascular disease. So high physical and social, again, the difference between the African and the Caucasian, and compared with the general population, rheumatoid arthritis patients have a higher risk of osteoporosis due to inflammatory nature of the disease, long-term corticosteroids used, and decreased physical activity and exercise. Education as an integral part of any chronic disease management, and structured education is the part which we always stress if you would like to develop a partnership between patient and providers for long-term follow-up. So developing educational program tailored to patient needs may help increase knowledge about the disease, and may serve to increase treatment complication and reduce rheumatoid arthritis disease. There is a model from Morocco, study population, a group of 39 rheumatoid arthritis patients in Morocco. Patient participated in 3 days per week educational program. After 3 years, the disease activity status was significantly improved in this group versus controls. There was no significant change in functional status between the 2 groups. And another studies, education, counseling, and behavioral treatment of patients were associated with small but significant short-term benefits, as we can see, of the importance of structured education for rheumatoid arthritis patients. National rheumatologist societies in different places come with the register. There is an important points about registers. We are talking about registers in diabetes, register in cancer, register in rheumatology, and when we talk about registers, we are not talking about personal information. We talk about the proper follow-up of the patient and the mission and anything related to the outcome of the disease. So the National Rheumatology Society was established the register for early rheumatoid arthritis clinic. Data from this register will help to understand the reason for delayed referrals, the easier to true burden of rheumatoid arthritis, to estimate associated complication, and to guide rheumatologists on the need to modify treatment strategy. Sharing this data with patient and primary care practitioner will serve to improve the awareness of rheumatoid arthritis and the early referral. Patient will not be kept in primary health care for a long time till start to develop complication, and then you see cases very late. In DHA, we take steps on that, and we developed the mandate, which we published in 2018, and effective from January 2019 for EPP, or Essential Benefit Plan, patients who have no access to the originator drugs or the biologic. So we keep it as mandate. If patient for medical necessity, they can use this medication. So in conclusion, in light of existing barrier to early diagnosis and optimal treatment of rheumatoid arthritis in Africa, Middle East, and all this what we saw from different studies, treat rheumatoid arthritis early and aggressively with combination of traditional DMARDs in patients with poor prognostic market, particularly markers, particularly those to resource poor region. If there is a resource, minimal resource, you can go with DMARDs early in treatment. Initiate educational program to improve the identification of early rheumatoid arthritis and the rate of specialist referral, so the treatment can be initiated earlier. And this is the role of everybody. Once the guidelines is out and the consensus agreed upon, we are going to disseminate to the first line. First line is primary health care physician, and one of the criteria is when to refer. Design the implementation longitudinal epidemiological studies, a better estimate the prevalence and burden of rheumatoid arthritis. Develop educational program for rheumatologists to increase awareness of remission and the low disease activity, targeted treatment, and improve the long term of prognosis of rheumatoid arthritis patient. Update national standards, which this is what after this session we will take the next step with Dr. Jamal in order to have our standard published in our website. Adopt and align approach to clinical and economic value behind sustained remission between clinician, providers, and regulators. This is end of my presentation. Thank you very much for listening.
So further, we have questions. Can you ask now or
Insurance
later?
or,
You can ask if you want.
you ask insurance.
Sure.
You are the expert in rheumatology.
No, I just wanted to know, when you said there's some patients who don't have access to the originator.
Yes.
So on what basis is patient selection based?
We have two categories of patients. We have the enhanced plan and the basic benefit plan. Enhanced plan are patients who have their salary more than 4,000 dirham per month. And the basic benefit plan are patients who have their salary less than $1,100 per month. So these patients are the essential benefit plan. The basic coverage for this type of patient have the mandate of basic benefit plan. So these categories of patient, their limits is 1,500 dirham per year for treatment, except if they can be treated for emergency, and for cancer, for example, they can be covered for up to 150,000 per year. But if they have a problem with rheumatoid arthritis and you prescribe biologic for them, if you write the proper report and there is a medical necessity, it will go to insurance with the mandates which we published in 2019, effective 1st of January. They can approve it for them to use this type of medication. I'm talking about Dubai.
Right.
So, coming back to the same question, for the basic plans, we do not get approval even for methotrexate. Patients have to pay for it. I'm not talking about biologics.
Midnight Dubai.
Midline.
No, I'm calling him Midnight.
Most of the policies.
I know, Dr. Qasim, he approved. You approved, right?
We approve.
They approved.
None of mine are patients, but I mean,
If
if there
you
is,
have-
yeah.
If you have
Yeah.
any problem related to you did all your work, documentation, and referral with report, and we didn't approve, we have in our website, ISAAD website, there is I Promise. I Promise is a link where you can share with us the case, and we give you answer in 24 hours. If it is a medical necessity,
He gave you his word.
Thank you.
Bank account, please.
you know the beauty about Dubai, when we are talking about medical insurance, we have all parties are sitting on the same table. We are discussing, reach consensus, and then we agree.
Thank you.
Thank you very much.
Thank you, thank you.
Would you like to have the black and white?
No, it's okay.
Yeah?
Thank
Sure,
you.
no problem.
Okay. Right, I think we'll move to the next speaker. It's my pleasure to present my colleague, Dr. Athir Al-Ansari. You can see his biography here. And Dr. Athir actually is a graduate of Baghdad University with postgraduate training in UK. And we are colleagues also. We work in the same establishment, which is Mediclinic. I work in Mediclinic Wellcare Dubai, and he is in Mediclinic Airport Road in Abu Dhabi. So I'll ask Dr. Athir to come to the podium because all is mentioned there regarding your biography. And you'll be talking about how to narrow variance between different remission criteria.
Thank you very much. Is it loud enough or you need a microphone?
We can hear you.
We can use this
I
one.
can also put this one.
No, that's fine.
Okay.
I know the audience are mixture of professionals, so therefore we might need to go into some principles to understand the problem we are here about today. So, first of all, over the years, rheumatoid arthritis, to many of you might think is only a musculoskeletal problem. But our understanding of the condition is a process of complex mechanics, started from inflammation that we measure by the CRP test. Inflammation on long term can cause some damage. We see by X-ray, ultrasound, MRI. And this damage in many ways can lead to symptoms, restrictions, and some pain. However, the inflammation itself can lead to symptoms as well. And how we measure the symptoms is we rely on two sources. One, a source from patient to tell us much about the symptoms and how they feel, and one what we see ourselves in terms of swollen joints, tender joints, and some other observation. So the process is so complex, we cannot say just simply you have active disease, you don't have active disease. We will elaborate on that. But when it comes to patient, how they describe themselves, they are mainly concerned about pain, but also they could mention fatigue, morning stiffness, also psychological element of the problem. And by figures, most, let me say, prescribed symptoms are, in many studies and registries, are these what we call self-reported by patients. In many ways, there will become a discrepancy between what the physicians see and our patient say. So they, over the years, established tools, what we call it, try to mix these two opinions together between what the patients say and what the doctors see. And there are few, let me say, tools. The DAS28 is one of them. When we measure, let me say, calculate the tender joints and swollen joints, there is a pointer here. As you see, the first two lines, tender swollen joints, that's mainly is our task. But there is also what we call global assessment, patient global assessment, is to report these clusters of pain, stiffness, fatigue, how they feel about themselves. And also there is physicians global, what they think the patient is in what a real state. There are CDI and SDI are more simplified, easy to do it in the clinic. DASDI, we have to rely on computer to make the calculations. It's more statistical, difficult calculation. But these are the end of the story. Are these giving the real picture of what's going on? If we look at the registry and study trial data, over 10 years, you can see, according to DAS remission criteria, we are not achieving better than 40%, almost. To a less extent in CDI and SDI. CDI and SDI less used in clinical trials, but also what we see from these figures are also poor. And the Boolean one, I'll explain about Boolean later on, is a more stringent score, a mix between what the patient feels, what the doctor feels, and the condition is even more difficult. That's over 10 years. But what we see in 6 months, there are similar pattern. What the DAS give us in terms of remission, what the CDAI and SDAI, give us a similar pattern of what remission in RA could be. And what that tell us, if we achieve whatever score in the first 6 months, that may well could be sustained for another 10 years. So that does give us the highlights that we need to get this disease controlled early. Because if we miss the control the first 6 months, they are likely to be on the non-responsive side, and there will be a cycle of no response, no response, no response. So that's one of the important things I need to highlight today. So these are technically the measures we use. There are so many other measures are of less validated scores. So what is unmet need is still how the patient feel in terms of pain, fatigue, mental state. Many people, they want to feel as they are aware before they develop rheumatoid. Many people, they don't think they got to that status before having their rheumatoid disease. Pain-free, stiffness-free, doing everything in life, energetic. Many people, yes, we see they are in remission, but they are not quite there, you know. Only few of them. That's from patient aspect. But what is the scope of rheumatoid? Why we need to think about it? Are the complications? We tend to ignore these when we talk about rheumatoid. We think only on the musculoskeletal disease. But cardiovascular disease in untreated people is a 3-fold increase or more. I think Dr. Suad now here always enrich us with some more concepts and figures on that disease, which is quite important. So when we cut down the 3-fold increase to 1.5-fold increase with the best treatment, you are also minimizing the heart events. And people here, when they talk about cost, that's also something relevant to cost. And about health, yes, it's part of the health, because that might contribute to symptoms in some other way. Also, there are like vasculitis. We don't see much vasculitis these days, but also can affect other disease, concomitant disease like poor control of diabetes because they need some steroid or they need something else. Also, social aspect and osteoporosis in particular with active disease. The other part of the complication, and this slide from UK. In UK, with the gross elderly population, joint replacement was really burden on the National Health Service. The first target 38 of NICE guidelines is to give one chance of anti-TNF because they are of similar nature. That's what they say. And the one chance might well fail. And the British Society of Rheumatology and all rheumatologists in UK try to argue this point, and particularly US, Europe ahead of us. And one of the arguments being used is hip replacement figures. When you see before 2003, there was a linear curve for increasing of the joint replacement in general. And after the use of biologics, this curve started to come down. So you spend whatever money on that, but you have saved, if you imagine, a one case with a knee replacement end up with some complication of infection or cardiac event or pneumonia or whatever it is, stay 4 or 5 months in the hospital, that could treat 6-7 patients with biologics to avoid such a complication. So that we need to take this into account when we talk about overall management. Then we come, what is the best to do in terms of how to tackle this problem? When we have new therapies now, the new therapies showed in general, when you see the green line, the best they can achieve if they are given early, when they are still methotrexate naive. All TNF, IL-6, everything could give the best result then in terms of ACR20 and ACR70. And I remember a quote from Paul Emery, all rheumatologists, they know him. He say, because of the cost, we cannot give the best drug first. Why we don't give the best drug first? To stop what we call switch off the mechanism of inflammation. It has been shown as crucial. If you switch off this mechanism very early, you can get the best outcome of it. If you leave it for a little while, and that's when you leave it a bit with methotrexate, although it's a cheap drug, it can be effective sometimes, but then the response rate is not as good. And again, if you are after anti-TNF, which means someone already in the severe and the wheel of non-responding or poor responding, then the response rate will be lower and lower, and so on. It's a wheel of no response. We stop this wheel early enough is the best outcome we can get. This is a study from Japan, also talking about people might still have symptoms despite what we call it remission. And they found that the DAS28 is the least representative. And we saw that in our study that the remission in DAS is not the same remission in CDAI, which means DAS is not very representative. However, but DAS becomes so universal, everybody uses it. We can use it as a common denominator here. But again, DAS is not very reflective, and people who use Boolean scores, the chances of have residual remission is less, so it's better score, but it's difficult to achieve. So still there are unmet needs. We need to reach the best therapy if we can. So one of the key messages is we should understand patients and doctors are not quite the same in assessing their disease. Second, there is a pain, fatigue, disability, all you name it. And we need to use the PROs, patient-reported outcome, to the best way possible. Use of multiple of them is better always, and we know, but they can be reflective somehow. However, we need to get what we call it, something to even cover that aspect of disease through PRO usage. What is the strategy if we have a patient with active RA? Treat to target by small n has improved the quality in the physician's side, because we used to give medicine, look, this treatment for rheumatoid and go. Now it's not. It's a big responsibility on our shoulders. We have to achieve treat to target. We need to know the medicine we are giving is achieving the remission. That's the first target, let me say. Second target is sustain that remission. A lot of patients, whenever they get better after 2-3 months, automatically stop medicine. If they end up with a second flare, they are lacking methotrexate inadequate response or anti-TNF. They enter the wheel of, let me say, non-responder or inadequate responder. We need to sustain that remission. We need to do all the education to the patients. Particularly Middle East patients are particularly difficult compared to the European or Asian. And I showed that last week in a lecture. And so we have to sustain remission. And it's job of everyone around us, between physician, educator, payer, everyone, is to get this remission sustained. If we cannot get the remission, the patient already difficult. I have a lady who came like CRP 100 ESR, and she denied herself, but all her joints are swollen. She's been like that 9-10 months, although she's from Estonia, strange enough. But then I cannot get her to a full remission. It's poor prognostic sign, so I get her low disease. CRP dropped down to 15, which is the best we can achieve. But she's able to walk, less swollen joints and everything. And we need to sustain that low disease at least to minimize the complication later on. The Boolean mean remission, which I mentioned about, is very tough one. Means you get only 0 or 1 tender joint, 0 or 1 swollen joint, CRP less than 1, and patient global assessment less than 1. And the patient global assessment, for whatever you do, if they just say coming to say good morning, they score themselves 2 or more. To get a patient to score 1, they have to be very normal as before they having rheumatoid disease. That's why Boolean scoring in the clinical trials is not the best, because particularly of this element. But we, in my opinion, I might accept 2 or 3, because patients also bias to some degree how to rate themselves. If they have argument to husband and wife the night before, they come and score 3 or 4. That's a part of life, but that's not part of the disease, you know. So we just need to make sure Boolean has to be in our radar, has to be our target, but we need to understand it, how it works. Now, to sustain that remission, as we said, we need to look into other matter. What is convenient to sustain? People, they don't like tablets, they don't like injections, they don't like medicine. They have cultural belief against medicine, opposite to the European nation. But in this, let me say, convenience figures, a lot of them, as you see the first 3, a lot of them prefer the oral compared to injectables. I see few with the GI problems, they might prefer injectables. In terms of that's done perhaps on the tofacitinib days, when it's twice daily, we have once daily oral, it could shift more to the right, but in they prefer 6 months, so we don't have tablet for 6 months, we have Malthera for 6 months, that's the only one. But they prefer less medicine in general. So that also reflected by they don't want it combined with methotrexate, they prefer monotherapy, and also no allergic reactions, so that make them away from injections in general. So when we make decision, I can tell you all key opinion leaders in rheumatology, in UAE, the people you know, they look into all these different domains, try to select what is the best for that particular patient. Maybe some rheumatologists who are less exposed to the data, they might do some sort of error choosing not the best medicine for that particular patient. So we have to be careful about how to choose the medicine. And now again, this is another burden on us because we have to be up to the game. So when we come to other PROs, which called patient-reported outcome, this is more relevant to UK basically. The UK is all central when they give money through NHS, but also get money from taxation from industry. So people, if they miss work days, it would affect the central budget anyway. So they found out that offering medicine to get people back to work, it at the end helpful to the government rather than the other way around. And that has been shown by this study. Particularly if you start the treatment early and you achieve remission, you get almost non-loss of working days. From health perspective. They could lose it from other perspective, but not from health perspective. Compare if you only achieve ACR 20, which is the patient just a bit better, or somehow better. But still they lose a lot of work days. So, and I don't know how it works here, these mechanics with the taxation and industry and health. Maybe you have different system, different economic perspective, but for NHS is definitely is argument successful on this way. So we go by some summary keys, and then I'll show you one of the guidelines of the EULAR. So there is a lot to achieve. DAS28 remission is the common denominator for most practitioners, but I know many people prefer CDI, which is quite correct. Remission in general below 30%. We have long way to go, and we should be encouraged using PROs as much as we can, and we need to reach to what is effective in achieving remission and sustaining remission. Right. And I'll pass this one. This is just about the strategy of EULAR. Treat to target has, let me say, pivotal change of the physician's attitude towards tackling the problem. And they minimize the use of glucocorticoid, and they give a rational use of how to use methotrexate, and then focus more on biologic and targeted demands on this occasion. So I'll come to the main points. So B on the right, and they clearly focus on safety and comorbidity in how to select the right drug for the right patient. Just having a medicine that is scored higher on something, you choose it straight away, that's not the right way. You have to have comprehensive view. The other thing, which is the same on the right and left, which is rheumatology should be the specialty to care for people with rheumatoid arthritis. Why is that? Because other specialty are not aware of what we call it early switch off or disability or all these or PROs. They are not aware of all of this. They are going like old rheumatologists all days. They give medicine and go. That's if they do. Sometimes I only give it on NSAIDs. I think there is UAE law by, I think, Department of Health saying that it is unacceptable a specialty treat a patient with a different specialty problem. That could go, for example, I cannot treat stroke or heart disease. Yes, understandable. But rheumatic diseases are not orthopedic job. And here I ask all payers representatives to audit this one. And I did it in my hospital. We have 6 orthopedics. I say everyone with spontaneous action pains just do ESRCRP. If they are high, you should be referred to me. But I don't have authority on them. 2 of them did it, and 4 they didn't do it. And one of them, 6 years with me, did not refer a single case in rheumatology. That's really shameful. And I think authority or payers should take an action on this because it's a large-scale problem. Those people losing the yearly control and they end up in a cycle of non-responder or inadequate responder because of such a problem in the health system. Right, and again, we should have different mechanism. We understand these medicines are not long sustainable for reasons still not understood, but the immune cells in the body is like bacteria, might develop antibiotic resistance. So they are clever, they have brain and say, look, you are blocking this way, okay, I'll maneuver and go in a different way. It's possible that way, but still more to be elaborated on this one. And nothing really more to add. I think I delivered the messages I want to say, and thank you very much. Ready for a question? Oh, that's we'll pass that. Right. That's just the same. Every 3 months we do assessment with disease-modified non-response. We go to biologic, and if they are responding, fine. And that's basically the message through EULA guidelines. I just forgot to mention that. It's not something, yeah. Any question on this complex? Okay, question?
No, fine.
No, fine. Right.
I didn't want to interrupt you during the session, so
The clicker is here. Fine.
All right, okay.
It's because you can time and stuff.
Well, thank you very much. Thank you, Dr. Athir. I mean, you saved me a lot of slides, and we're kind of negotiating. Thanks, Abby, for the opportunity. I mean, I'm gonna go straight to the meat, okay? And this is like what we do a day. It's challenging to speak to audience and trying to get them on board. So please interrupt me if you have anything. I'll try to be straight to the point, not to dwell on different things. What I'm going to do, I mean, Dr. Athir and Dr. Ferrari have spoke about things. It's just, I'm going to run over this quickly, and then I'll focus in these two things because this is what ties us together, rheumatology and the health economics. So, I mean, over the years, the definition of remission have changed, okay, from when blood in 80s, when the methotrexate clinical trials came, until when they just visual analog scale, to what we see in the sophisticated, as referred by Dr. Athir in the kind of previous lecture. Now, if you look at it, I mean, DAS is the one commonly used, this easy stuff. I mean, we were trained. CDI and SDI, to my department, was introduced in 2017. People coming from state, etc., brought them with them. Bullion, you have the clinical trial and you have the practical one. So the practical one differs without CRP, which is interesting part. Each has ups and downs. For example, DAS28 relies on tenderness and ESR more than anything. Now, what's your preference? It depends on your preference, how much you want to be stringent. Okay, so why this is important for health economics? Because if I go down with the remission, I still have to treat and treat and treat and treat, and this is for them cost. So for them it's easier to be DAS28, less cost, however the sustainability of it very weak. So moving on. So for example, FDA will demand ACR and no changes after 6 months of stopping the medication. This is very stringent. Now, we know that the bullion is the toughest one, but let us not fool ourselves. As Dr. Athir nicely mentioned, the patient-reported outcome, is the one you can have patient with remission and be shifting between doctors, asking for more medication because he's not satisfied. And we have shown that with fibromyalgia, we showed that with chronic pain syndrome, and your value as well. I mean, the way you patients evaluate themselves. So it's interesting in a sense. Okay, so why we need remission? Of course, patient guidelines all cited in the previous lecture, patient report outcome. This is the must. And then why, I mean, this shown a disease reaching to a remission will improve the quality of life, your health, your ability to work, etc. Plus, for economists, that treating rheumatoid arthritis is really expensive nowadays. I mean, the days of non-steroidal methotrexate was cheap. Now the biologics era is like, wow. But imagine this, treating patients with active rheumatoid. Now,
You're going to treat him now, and you're going to treat him for life because he will be handicapped in the future. You will suffer. The government has to pay for it. So overall, it's a cost effective to treat him aggressively now and get him in remission. And a workability, the study what Dr. Athir referred to is this one. If you maintain remission, you maintain your work. If you sustain remission, you maintain your work of maintenance, what's called workability, as well as you reduce retirement. There are 0 in the study, which is from Finland, which is interesting. Now, the prevalence of remission. This is from Australian cohort, what started 2009 up to 2014, and what they looked at 15,700 patients. And what's important thing here, I put this slide. If you look at this, this is each color represents a year. It's increasing from 37% to 54%. The admission criteria here for remission was DAS28. So anybody at DAS28 less than 2.6, the remission prevalence was in 2009 around 37%. It reached 54%. Now this is mirrored by drop in high disease activity and moderate disease activity, which is interesting. And probably because in 2010, the treat to target came out. So it mandates that you have to treat to reach that target. And second thing, the access to biological DMARD. This is another study. This is Corona registry, not the virus. Corona. Corona is the Korean registry. It contains 5,300 patients, and they match it with the US registry. It's called Brigham. It's 1,300. So in total, they have 6,600 patients. So what they did is, funny enough, it's published last year, but if you look at it for one of the scholars there, what they looked at, those patients who reach remission in 2009, and by definition, by DAS28, it was 465. And they looked back into how many of them maintained it in 2010 and 2011. And surprise, is around 54. It's the same figure of the Australian, which is interesting. Now, when you go stringent, among these 456, 99 patients with CDI and the Apulian, but the people maintaining 17%. So as much you go stringent, they sustain it for 3 years. So what's the prediction for remission? The demographic have implemented comorbidities, treatment, laboratories, and genetics plus radiography. But and this is a summary of it, and that's why I don't want to dwell more on it. So let me make it simple. If you are a male, okay, you've never smoked, you don't have any comorbidities, at the time of the study, you were young, or the disease itself came at later age, if you are negative for ACPA, rheumatoid, or anti-CCP and rheumatoid factor, you're negative for both. If your disease activity at baseline was low, if your HAG was mild, if you never used DMARD before, or never used TNF before, or never failed TNF before, or you were on the treatment at the time of the study, and if you're lucky to have a gene polymorphism for folate and the doctor treated you with methotrexate, or your CRP was less than 20, or your interleukin was low, then you're likely to achieve remission compared to the opposite of any one of these. So this is the ultimate. I'm trying to just make it simpler. Now, the problem is this. Most of this data of predictors comes from randomized controlled trial. Okay, this is randomized controlled trial. This is real life. Okay, we wish to have that. I mean, in the clinic, you have patients like these. In real life, you have somebody old, large, small, and you have the people here like coming with rheumatoid stuff, with rheumatoid arthritis, like these syndromes. Okay, so this is real life. This is the real life, and this is what makes a difference for, I mean, the payers and stuff. That's what they want to see. That's the data from this. So, again, the same study Dr. Athir used. This is a record. This is a review from published last year. It included 8,323. They did the qualitative analysis on 31 study, but the quantitative analysis on 12, and most of them registries. And what they came up, if you are a male, if you are a high educated level, and your low-based disease activity, this is the one, okay, will predict you. Now, this is interesting because this is either reflects your insurance or your compliance. So there's a variable in it, but this is real life and this is what happens. What the gaps we have, what we when say sustained remission, what we mean exactly? Is it 1 day, 1 month, 3 months, etc.? We don't have, there's no consensus on that. Plus, there's no consensus, is it drug-free remission, biologic-free remission, or just remission, okay? So this is the gaps we're having at the moment. The study for Corona and the American one, they came with other things, short disease duration, no disability or HAC, and no use of steroid. So still we don't have a consensus on that. So coming to the local data, this is like an exercise we did, we started early arthritis registry in 2014, and we moved to it. And in 2018, we brought the cost-effective study because as a mandate, I mean, he's not here. We wanted to persuade the payers that the cost effectiveness of treating biology because they think getting tighter. So we start this and with the SPA as well. So two studies going that side, approved in June 2018, and we carried it on. So we used that opportunity, and this is 3 years. We're going to end it in 2021 unless we extend it. And the registry is, we have in the registry 532 patients meeting the criteria with RA. So the primary objective, just to describe the prevalence of RA, of remission in RA patient and the sustained remission, plus looking at the predictors. I won't bother you with the thing, I will explain to you as we go. It's a prospective study. So these are the variables, and this is what I'm going to dwell on. This is the demographic, including the insurance coverage. We are faced with the insurance, by the way. That's not only the private. We kind of have things for justification and stuff. Even with methotrexate, if we give it oral IV or subcutaneous, they ask us about it. So, and this is disease-related outcomes. I mean, your even presentation, if you come late, delay, we're counting that, and we have the data on that. And the blood test, DMARS biologics. Now, as mandated, as kind of normal practice, standard practice, that atherosclerosis cardiovascular, because we are a large organization, we have more than 16 clinics, primary healthcare, and plus 4 hospitals. So it's you found that the primary healthcare doing the cholesterol, etc. We kind of came up with a way to appears in our system. Whenever the patient comes, it's coming in our record, and this is mandated. We have a KPI for this. It has to be every year. So we have the atherosclerosis cardiovascular risk plus Charlson comorbidity index. What this tells you is what's your risk of dying because of comorbidity in 10 years. So it tells you a 90% risk, or et cetera, et cetera. Plus we do the comorbidity score and the ultrasound, Ahmed's doing it. So this is another thing. This is the compliance part. The compliance, we assess it in a funny way. There's tools to do it, but we use this way to be more practical because the registry is built up that people doing their work, normally, it comes in the registry, so we don't have to hire somebody. So the compliance, we ask if your patient methotrexate a week in a month, it comes as 25%. So it's in this, he will come in this group, not that group, okay? And then we verify it. And this is the verification part. Now, this is actually a real patient. And this patient, we would like to have things like this, continuous. We don't like the interruptions. Okay. Now the interruption, you can argue, not in this case, he might go to the private to get medication, but being the government looking into it, and NABOT, I don't know, the payers know about it. NABOT is unifying the medical record between the government and private, and this will be sorted out by next year. But this patient, for example, she stopped her medication. She was admitted in hospital. What you see here, injection sign, is that every day, it's like tofacitinib was given on that days, and then prednisolone. So this is, and she's reading methylprednisolone as well on the side. So it tells us where we're going. Anyway, so we have invented few definitions for this exercise. For example, missed follow-up in 2018 means that patient was not assessed for 6 months. They come for refill, they send their daughters or whatever, or the patient did not, or the doctor did saw patient but did not do the evaluation, and this will be excluded. And lost follow-up in the prospective side, we kind of said if the patient missed an appointment for 4 months or not assessed for 4 months, he's out of the study. Okay, this is lost follow-up. The definition of remission is have CDI and SDI according to criteria. You relapse if you leave your class, you go to the higher class. This was the definition. I won't bother with statistics. So this is the design of the study. This is the recruitment phase. Okay, we move on verification. This is our entry point, the fourth quarter of 2018. Okay, so we see who's in remission, who's not, and we follow them for 1 year. And then we compare them with these people and the whole group, people with active disease, okay? Now, this is the number of patients, this is activity measures per visit. So I mean, percentage-wise per tool. We're doing the three tools. The fourth tool is combination of getting the global, but this is an average what we're doing, okay? And this is we're monitoring it on 44 patients. The reason for that, we eventually got 470 patients fitting our criteria for in the study, because some of them have lost follow-up before 2018, before June 2018, etc. 26 missed follow-up in the journey, so we brought them out of the study. These people was more than 6 months. They're sending their daughter. They did not come. The doctor did not do the evaluation. We took them out of the study to start with 26 patients. So we end up with 444. And we took them, of these, 120 achieved this remission. And these people are active disease. So moving on, this is the breakdown of it. Majority are in the target, because one way we're doing it in our hospital is that the doctors are monitored by the system. We kind of have a report of quality. Who's doing this at this process as a KPI, and it comes in the evaluation as well as their outcomes. This is one of their evaluation system. Anyway, so cutting it long story short, we compared the two groups, people with remission and people with active disease. They have similar age, the gender is same, smoking the same, biological exposure the same, the BMI. What the important thing is disease duration. Those in remission had a shorter disease duration compared to the other one, the people with active, and HAC was striking. Now, comorbidity was not an issue. Your cardiovascular risk was not an issue in this. Okay, let's move on with this, and I will tell you why this is made. Now, in terms of the medication, they have the same percentage of DMARDs, biologics, JAKs. This is at the quarter. And switching biologics, they had higher, two of them because immunogenicity, 2 patients here. The rest is just non-responder, second non-responder. Prednisolone as well used was the same. So with the meta-analysis for that, HAC is the only, sorry, we did the logistic regression. HAC is the only one came out as important when it comes to people in remission and people not to start with. And this is the HAC at start. So this is basically the results of the study to start with. So this was all preparation, nothing we did not move with yet. Let's move for the perspective part. Now, this is where the fun starts, going this way. Okay, so going forward, this is again, what we do is the follow-up in 2019. This is pure. This is an example of a patient. I don't know if it shows here. You see the dots here. First of all, you see green, yellow, red. Okay, it tells you your remission, moderate, low disease activity, moderate, and then active. This is the, low disease activity, this is the active disease, whether moderate or high. Now, these dots represent, this is from DAS28, by the way. These dots, and this is in the system, it represents the visits. So let me close, I can't see it here, I can't tell you. What you see here, 1, 2, 3. The gap here, here, it was February 2019. And they're seen again in July 2019. So this is 5 months between the visits. And this is out of the study. So they lost follow-up in the prospective side. So this is one of the patients. So what happened is, we followed the 120, we end up with 114. 6 of them we lost them, 5 of them because lost of follow-up. One because unfortunately she died because of cardiovascular. And we, of course, we have the other group. So what we did, this is the Kaplan-Meier of sustainable remission. If remission by CDI and SDI, what you see here that 70% they maintain, if we measure DAS, it's still maintained. Okay? If we measure CDI and SDI, around 34%. This is 1 year. This is quarters per the year. So where the other, this is the diseased one, this is the remission. The other went into low disease activity as a group, and we have less and moderate disease activity. Again, we did the same exercise. We compared the 2 groups. And what you see here, the age became a factor for interest. Disease duration stayed. Now, this is another thing. If you are rheumatoid factor positive and ACPA positive, you're likely to be in active disease. And that's what's significant in our group. So it's inverse relationship. And HAC remain the one. Your cardiovascular, your CCI, Charlson comorbidity score was normal. Again, the biologics, the DMARS, the combination was not an issue. Switching, there was no switching in between. Prednisolone used in 2019 was the same. There was, some people are tied to it. What is interesting is the compliance rate. And giving the score we used. And logistic regression again, HAC, being a male was advantage. It came out as an interesting, we put as a control. It came as an important one to predict very small group. Compliance still, but it's a weak correlation. And disease duration was there. So this is the one in gray on what you call univariant, and this is on multivariant. So we said, okay, let's take this further. The HAC is still important. Just remember the HAC when it comes to this. Now let's move into other partners in this meeting, the impact on health utilization. So what we cover is the number of specialized admission, lab investigation, biologics, HAC, etc. And I have to do that. Now, when it comes to number of specialized visits in terms of rheumatology, because it's a study meant to have, there's a criteria for loss. If you kind of apply, if you keep it as good, the people lost follow-up, they fall into active disease, so it'll be less visits, so it's not direction. Lab investigation is a standard that you need to read the labs before, so there's no major cost of it. We have a standard to repeat the cardiovascular, your diabetes, etc. every year, and your regular full blood count, liver function test. So it did not show you much difference. Now, sick leaves. People working in UAE knows about. When the patient comes to you, give me a sick leave, a culture. I was telling the prof yesterday, he says, this is a culture, they want day off, so make them happy. Retirement, we did not have any retirement in our cohort for that to start with. Now, what I'm going to focus on admission, workability, and the HAC, of course. So this is the records. This is the records of the admission. I know you can see it, but we had 33 admission, 2 of them readmission. If I magnified, I'll read for you, Zoster without complication, and then it came up with ophthalmology. And of these, okay, rheumatoid arthritis kind of admission related, it was around 21%. So we took that and we classified according to disease. Those in sustained remission had 1 admission. Those with active disease had 30 admissions. Now, this did not reach statistical significance when we did the Fisher exact, sorry. But the payers don't need this kind of statistics for this. They're going to pay, 4 times the people they're going to be on remission. Logic in this cohort, okay? And this is real life. Now, remember the HAC was the issue between the 2 groups in remission, sustained remission. We took that and we worked with, there's a study kind of looked, mapping the HAC against different. One challenge of this study here, because we don't have what's the normal HAC in general population, okay? You have to normalize it before you applying it, because it's nice as applied as a tool. It's been validated as a tool to how to fill it, but what's the normal range? What's your distribution? So, internationally reported depends on your BMI, your level of activity, your education, but we don't have that. But anyway, let me go back here. Just remember this number, 30.35, and this one, 0.9. So if you put them here, this is the people in remission will fall in this, and the people with active disease will fall in this. And if you forgot all what published in the state, etc., you come to the last from UK. This is because this is published 2011, so they took this data. So if you are in active disease, you are likely, the payers likely to pay 3 times more people in remission. And this is fact. If we just map it at this, okay? Without taking your GPD, etc. Now, we took it another step further with workability. We just got the tool of how to convert it. And workability, for those who don't know, is a self-reported questionnaire assessment amount of if you are not coming to work or you're staying later at work to finish a given job. Okay, this is cost as well. Plus, it kind of assess your activity impairment because of the disease. Now, Zhang kind of map it validate for rheumatoid arthritis, 6 questions. And again, we're using the hack to do it. We went out with two assumptions to do this exercise, that work productivity and activity impairment is based on 7 days, the last 7 days. We took it at the last quarter. This is assumption, as it's been always the same. And the other thing, we took the average salary in UAE, that's annual salary is 118,000. But again, I can tell you from our group, we have people high achievers, they're holding good position. The salary is just, this is probably the smallest one. We took the worst case scenario. So when we're doing that, there was a difference of 0.6 between the two groups, and this ran to be 0.9 as a factor. We converted what appeared to be that people spend 9% of their time in addition to do the work. Plus, if you convert to money, they're coming to work and everything, but the government losing $3.5 million, $1 million. It just not achieving mission. Did not. If we map it per salary, I can guarantee you this will go 5 times higher. Okay. So what's next? Of course, we appreciated the problem from the beginning, and we started with the society because Prof would be interested in cost utility, and the cost utility was for this is part of the cost effectiveness as a trial. So what we're trying to see if treatment A or treatment B, which is best fitting for the patient, taking all the variables. We had a fund for machine learning to use it, and we kind of combined the model for it. We have shared with the society because we try to have people coming on board of us. It's not only us. We have 7 Emirates, we have more than 100 rheumatologists. We'd like them to be part of it. And the minimum what's required is 100 patients, and Emirates ID will do to identify the patient in between. And of course, we have deadline. We did this step. We're still welcoming people to come to move on with that. So in summary, I'm trying to make it, remission is a quest of everybody. Physician, patients, payers, government, what regulation, it's a quest, societies. Now, it's remission achievable in clinical practice. However, sustaining it is hard. So it needs a vigilance. It's a partnership between patient and doctors as well. It's not only the doctor, not the payers. It has to be a partnership, everybody to sustain it. Now, sustained remission will eliminate waste in healthcare, eliminate waste of medication, eliminate waste of time, government. So it's something goal we'd like to have, and this is for real world data to way forward. And we have, as you said, I mean, the speakers mentioned that culturally we have differences, we have interpretation. I was telling the Prof that the patient comes to you, tell you alhamdulillah on everything, although he's having disease. So we have to work on these different challenges. Okay. And of course, the team kind of were great enough to help me with this, put in the data. Thank you very much. So are we okay with time?
Yeah,
or we can.
You can have the Q&A. Yes, because I'm sure that there is a lot of Q&A is needed here in this session.
I thought because Professor Lee and I were discussing.
Dr. Jamal, first of all, let me congratulate you for such beautiful work. It's amazing. I have few questions. You said the presentation of duration, you chose 42 days based on what?
Yeah, this is the EULAR guideline for whether it's early or late, and we were into that exercise from starting early arthritis, and there's a publication I'll share with you. This is from EULAR, saying it came in 2007 and reply again based on French study, saying the guidelines came in the guidelines 42 days as from symptoms to treatment.
Okay. So if you convert 42 days, that will be equivalent
6 weeks.
6 weeks, okay.
That's 6 weeks.
All right. I have another question as well regarding the number of admissions.
Mm-hmm.
Why did you decide to do Fisher test rather than chi-square? Your
Okay.
sample size is quite sufficient.
Okay, the Fisher test, because we're taking the percentage, it's a small percentage in the group. The small percentage.
Your
Yes.
sample size is good for chi-square. Probably this is
They're
why you didn't get a p-value.
But again, the p-value is when chi-square we tried it in graph, it doesn't work, but the Fisher was used in all ways. And it's not normally distributed in parametric.
All right, I have some suggestions as well. You mentioned that about HAC and the significant findings with HAC. Some studies showed that HAC is an independent and important factor to determine the cardiovascular disease. So as long as you told me before that you are assessing cardiovascular risk in your patients, I think it will be good if you try to correlate HAC with cardiovascular disease. I'm pretty sure you might get some results out of that.
Well, actually, the comorbidities, you see, there's cumulative comorbidities and there's incident as a perspective. Because there's a patient, there's a registry, you know, there's a cumulative. People have inherited comorbidities from before. When we correct HAC, we have to correlate it at the spot. And of course, this is included as one of the outcomes, what predict cardiovascular. A couple of my residents working at the moment just to verifying the type of cardiovascular the patient had, and of course, I will take that on board. I'll take that, thank you. Along with the CRP. Yes.
That was excellent presentation,
No,
Jamal. I really enjoyed it.
No.
Just a quick question on, I may have missed it. All
See,
your patients,
what you're raising here is good for me because I'm going to write it up, it's good for me.
all your
Don't think it's
patients,
negative.
ethnicity, they were all Arab ethnic
Yeah,
patients?
it's what I didn't come to that. Very good. It's, I mean, Dubai Hospital, 8% is Emiratis. Okay, we have in the non-local. What you see in the sustained remission, people are 100%. They tend to be Emiratis, to be honest with you. Okay, well, I think one, if I'm pretty sure, one is non-Emirati. Now, the others, there is no denial of treatment. We had an issue of compliance as the big thing, that people don't want to come for the copayment stuff. Okay, but this is the minimum. Yes.
Okay. Now, the second question on HAC.
Hmm.
Do you use the usual hack that we use everywhere? Because I have a major challenge,
Okay.
especially for some of our local patients.
I'm blessed because...
Is there a variant
no,
of
just
that?
one second. I'm blessed because the electronic medical record, I had the time between, I was medical director, I stepped down and came back again, brought me back again. So I had the pleasure of designing my medical records. So the hack, we have the Arabic, the English, etc., all there. And we have the license for it.
I mean, I would
In
love to-
the medical record, it's not
I
like
will
somebody.
look at that. That's fine. It's just because, some of the questions on hack, for instance, are you able to do your household chores? How many of our,
I tell you something, vacuuming. Who's doing vacuuming now?
exactly, gardening,
Garden,
vacuuming,
okay.
lifting 5 kilos
Yeah,
of potato
I
bag?
totally.
Nobody does that.
Yeah, I know, but you're
So
right.
you have a modified one for
No,
our
no, no,
local
no, I didn't modify it because I don't want to validate anything. I'm using the old version of it as it is. People, the nurses have helping to fill it. The challenge how much I'm going to face in the future is that we convert this questionnaire to my chart, which is they can fill it at home before they come to us. This is my challenge.
But how reliable are their answers?
This is the
for
problem
these
validated
questions?
when you come.
Sure.
Yes, sir. Yes, sir.
Sorry, Yasser Gidani has the modified one.
Thank you. We use that. We use that, the modified one, for scientific, but for other study. But for this one, we're using because actually we kind of in the EPIC they have rights. I mean the copyrights for this. They buy as well as the EDQ5. EQ D5 D5. They have it there. SF36. They have the right for in the medical record. They bought it so we can use it in a sense. But with this, using it's not this challenge. The challenge is when you apply to the general population because you have to put in the context for normalization, what you accept as normal. I mean, you mentioned nicely, if the wife kind of had a discussion at night, the next day is, okay, so what's the normal in the population? This is
Yeah,
important.
exactly, because many of those questions do not apply to our local population and women. As I said, household chores, using a tub, get in and out of tub. I think some of them are not really,
Yeah.
compatible.
We tell you do that.
Yes.
That's what we explain to them.
Dr. Jamal, one more question before
Yes.
the coffee break.
مرة يوسف من عين hospital pharmacy department.
No,
My question from pharmaceutical point of view.
tell me.
Still, I can see methotrexate is challenging.
What's that?
I mean, you can start 3 patients.
Yes.
So it is only money-wise, you would select the biological?
No.
Methotrexate doesn't disappear.
No, no.
Still is like-
It still has group, and I mean, I showed it. Still, we have patients taking DMARS, taking biologics. There's no one size fits all. Okay?
I know, but
It's been there
because
from.
of their poverty, they will be
No, because of.
for poor population. They
No,
will
it's
get
not.
biological. I
I
mean,
see.
it's
When
not
it comes
right.
at the ethics, and Dr. Fardali will tell you, I mean, he showed you, I mean, did great job before, and the idea, there is no patient will be denied treatment because of the cost. Even oncology, people come to us in the hospital, and he knows that we had a meeting the other day. Even if they have, I mean, you can't deny that. It's unfair. Because we are based on His Highness Sheikh Mohammed when he said, I want the treatment for local, non-local. visitor and resident to have equal rights. Now, the point is, the challenge is how you explain to the payers that this is the right. Yeah, no, not you. Okay, so the point is you document that in honesty, and you're open to audit, and that's what we're doing.
I am still can compete.
Yes, Computexcel still have, yes.
Still have it, so,
Yeah, there's a lot of, I mean, there's a good group, 75% in our sustained remission, our mystery on DMARS only. So still there's, yes. But the problem is, what I'm telling you, what's the convenience for the patient? To have tablet every day, every week, or to have injection once a month or once every 2 weeks. This is the other thing. Yes,
So we are going to have actually during one of the sessions, which is the major concepts of health economics with Professor Lehman, there will be an open debate on this session exactly between Professor Lehman and Dr. Jamal. So now we have a coffee break, 15 minutes. Before you move, please don't forget there is an evaluation form in front of all of you. So please, we want your feedback. Please move. So now we have 15 minutes and we'll be back by 11.
Okay, now we have the pleasure to welcome Professor Levine. He's senior professor in health economics, and he has under his belt several titles. I mean, world-known expertise. He has more than 300 publications in this expertise, and talking to him is a passion kind of on this subject, and I enjoyed last night's discussion. Plus, he has several books in the matter. He will entertain us today about the value of innovative medicine beyond price, okay? And we're going to have another session later.
اوكي شكرا السلام عليكم صباح الخير لا أتكلم عربي only 5 words. I just mentioned the 5 words that I know. I'm really happy to be here, and I'm invited by AbbVie to give today during the conference 3 lectures. I start with a lecture on what I call the value beyond price. When we look at medicines, the first thing that we see is the price. And I would like to share with you a story about what are the other things that matter and how should we ideally evaluate the value of a medicine. I start with what I call the objectives of a good healthcare system. A good healthcare system will try to optimize the health of the population within the limits of the available money. We don't have all the money of the world to spend on healthcare, but with the money that we have, we try to do the best possible for our patients. And in an ideal system, we do that also within an ethical framework. That means that we try to help everybody. So that means that it's kind of a human right. If you are sick, we try to help you. It's not only good for the person itself, but also for the economy. If people are sick and we can help them with our system, with our health insurance system, they will get more productive again, and then it's good for the economy overall. That's the principle. But it means that for innovative medicines, we have a challenge, because on the one hand, those innovative medicines will improve the health of the population, of course. On the other hand, what we see in the pharmaceutical world, new medicines are almost all the time more expensive than the old ones. The biologicals are much more expensive than the DMARDs, for instance. And so we have a challenge. And the challenge that we formulate is that we have to make available and stimulate only those innovative technologies and medicines that clearly offer an added benefit compared to what we have today, and come at a reasonable cost compared to their benefit. So we have to look at the cost benefit of those innovative medicines. And of course, they also have to fill an unmet medical need. We are looking for new medicines in those areas where there is still a lot of room for improvement. Now, we see recently a debate in many countries in the world, and the debate is about, on the one hand, people who are concerned about the money. They say, yeah, but these new medicines, they are so high prices, also in cancer and in genetic treatments, high prices, our budgets will explode. And on the other hand, those who think more clinically, they say, yes, but we need those new medicines. It's amazing what they can do, and we can improve the quality of life of our patients. There is a huge medical need. So there are 2 approaches for the price of medicine. The first approach is what we call the cost plus price. Cost plus price means, dear company, AbbVie or another one, show us how much did it cost to produce, to develop your medicine. We give you a price to cover your cost of R&D, we give you a small margin, 20-30%, and that will be your price. That's the cost plus price. It sounds very reasonable. There are a couple of problems, however, with that approach. So it's fine, but there are 3 problems. What are the 3 problems? First of all, what is the true cost of R&D? The company is developing many molecules. Many of these also will fail. So what do we do with the cost of the failed developments? Do we have to recover them in the price of that one product that makes it to the market? And how do we do that? If you think about that more, the more failures a company would have, the higher the price of the one that makes it to the market. It's not really logic. Second, it's also wrong incentives. So, dear company, if you spend a lot of money on R&D, you get a higher price. It's not really a good incentive. And finally, and that's maybe the most important, in the cost plus approach, we don't make a difference between a really good medicine or just a marginally me too like medicine. So if you just get the price to cover your cost of R&D, we don't look at if it's really much better for our patients, that product. So the alternative approach is what we call value-based pricing. In value-based pricing, we give those medicines that offer more value to our patients, that are really helping our patients getting a better life, they get a higher price. But what is then the problem here? Some companies are a little bit too ambitious with regard to their price. They say, oh, we have a fantastic medicine, we can ask the price whatever we want. And that's of course not working either. And a second problem is, at the time of where they submit for getting reimbursement for the system, there is still a lot of uncertainty. They have done a trial of 1 year, for instance. We don't know what will happen in the second year, what will happen in the third year. So from the payer perspective, if I am a payer and I'm asked to pay for that drug, but I don't know what's going to happen with patients in year 2 and in year 3, I'm not so happy to pay. So there is a lot of uncertainty. Okay, how do we deal with that? Well, part of the solution is, of course, first of all, that we have to do a very thorough, what we call health technology assessment of the new medicine or the new class of medicines. First of all, we look at the effectiveness of that new medicine, of course. Second, we'll look at the medical needs. Do we really need it? How much are these patients suffering? Is it more a comfort problem or is it really a severe problem that we are treating? Then the cost effectiveness, I will explain how we do that. And then finally also the financial impact. If all the patients would get the new medicine, how much will that cost in total to our system? I'll start with the effectiveness and the cost effectiveness. We in health economics, we apply the famous QALY. Everybody have already heard about the QALY, quality adjusted life years. The concept itself is very simple. Imagine we are now here, we have a patient of 60 years old, and the patient has a life expectancy of 20 years, and the patient is suffering. Normally, perfect health would be 1 on this scale, perfect health, and that would be 0, and this patient has a score of 0.5. We call it in our jargon the utility level. It's an economic term, utility. It's kind of a quality weight. 1 means perfect quality of life and 0 is that. And this patient, imagine, has 0.5. If for the rest of his life this patient keeps on suffering and for 20 years has only a quality of 0.5, the patient will have 10 quality adjusted life years. So 20 years in perfect health would be 20 QALYs, but 20 years at only half the health is only 10 QALYs. If we can improve the life of that patient, let's go to 0.6. So we improve the life of the patient with better treatment. Now we have 12 QALYs. So that's why you see here +2, because we are adding 2 QALYs to the life of that patient. If it's a life-threatening disease and we can prolong the life of the patient, then of course it will depend on the quality of life of that patient. If you have patients with terminal disease of cancer and you still want to prolong the life of the patient in very poor quality, you will not gain a lot of QALYs. But here, in this example, we gain 2.5 QALYs. In some diseases, like in cardiovascular or in cancer, we can improve the quality of life and also improve the life expectancy, and then of course we can gain a lot of QALYs. I spare you the details, but I hope the concept is clear. If we have an effect on the quality of life and or the life expectancy, we can gain QALYs. A more realistic picture, if a patient suffers from a disease, quality of life goes down, and then maybe stable for a while and then go down again, then that is the story of that patient. If we have better treatment, we can prolong the better situation, we can avoid progression of disease, and the patient will be in better health for a longer time. Of course, the patient will also die, everybody will die, but the difference between the two curves, the dotted and the full, that is the gain in QALYs. Okay, the first explanation here was a little bit artificial. Your life is flat and then you die. It's a rather boring life. So in reality, it's more fluctuating, but the concept is the same. It's the surface below the curve. That's the number of QALYs that we have. And if we can extend that curve, we will gain QALYs for our patients. I'll give you a first example. This afternoon I give more examples. This is an example. On the left side you have women, on the right side you have men. Two different definitions of remission and disease activity, the CDAI and the DAS28 with the CRP. But no matter how we measure it, we can come back to that later, no matter how you measure it, those in remission have on that scale between 0 and 1, they have 0.84, which is almost the same as normal. The average in the population there was 0.87, that was in Denmark, and so the remission is 0.84, and the more severe your disease, the lower your utility. So somebody with high disease activity only has about 0.5, depending on men or women, or depending also on the way that we measure the disease severity. Then to cost effectiveness. What we do, we look at two dimensions. The cost by convention is on the vertical axis and the health effect expressed in QALYs is on the horizontal axis, and the current care is in the middle. Imagine we are back in time and the only thing we had were DMARDs, then the DMARDs were the comparator. And then we say, oh yeah, now they are biologicals and they cost much more. The only thing that some people see is the price, and that's this one. But in health economics, we also have to look at what we call the cost offsets. Because of better treatment, people will be less hospitalized. We have seen from Dr. Jamal, also those in remission have less hospitalizations, more to come on these local data, but also less consultations, less imaging techniques, etc. Sometimes the cost offsets are so spectacular that the cost of the drug is completely compensated by the cost offsets elsewhere in the system. That's a fantastic story. I have to admit, most of the time we see cost offsets, but they're not enough to compensate the price of the new medicine. You see the red arrow, it means that even taking everything into account, the new treatment is still more expensive to our healthcare system than the current care. It's going to cost more. But then we look at the QALYs, and then only we can come to a conclusion. I'll come back to the conclusion, but first one more remark about the costs. Costs can be looked at from different perspectives. It can be looked at from the perspective of the hospital. What does it cost for me and for my hospital? In terms of nursing time, in terms of operating time, in terms of number of days in the hospital. The most applied perspective in health economics is the healthcare insurance perspective or the National Health Service perspective. And the broadest perspective is the full societal perspective, where we not only look at what are the cost offsets in the healthcare system, but we also look at productivity, absenteeism, and presenteeism. Absenteeism, people cannot go to work. Presenteeism, they can go to work, but they're less productive on the job. In the ideal health economic evaluation, I'm already destroying the local material. Sorry. The ideal perspective is the full societal perspective. But it means that we have to open then our minds, not just look at our own budget, but look at the full society. Okay, I'll give you an example. This was the paper by Radner that was already mentioned by Dr. Attir. That is a paper in patients in Austria, where you can see the direct costs, so medical costs, cost of the treatment. Most patients in that study were on DMARDs, that's why treatment cost is quite low. Then the cost of sick leave, so people are still active people, but they are on sick leave for a while. And then the bulk of the cost was people who were declared disabled because of their arthritis. So they're not going to come back anymore to work. They were long-term disabled because of their arthritis. And that is clearly the biggest cost. But even in remission, there are people declared not anymore be able to work. But you can clearly see the difference between remission, low disease activity, and then moderate to high. Now, back to our 2 dimensions. If this is current care, there are 3 possibilities. The new medicine is more expensive, but recovers everything by avoiding hospitalizations, etc. Also gains quality, so it means we go down on the vertical axis. The new medicine is cheaper for our healthcare system, despite the higher price, and we are gaining qualities for our population. We call it in our jargon a dominant medicine. We should definitely pay for it. We are winning twice. We gain money and we gain health. But sometimes, nowadays, we see new medicines that appear here. They are much more expensive than today, slightly more qualities, then we have to be fair and correct. This is not value for money. We cannot pay for that. We should not pay for it in our system. And then, very important, this one here, it's also in a green zone. It's cost more than current care, so it's going to cost more to our healthcare system, but for each euro or dollar that we invest, we gain proportionally a lot of qualities. We call it a cost-effective investment. We need to invest in healthcare, and this is a cost-effective investment. If you follow that way of thinking, of course, you understand that there is a threshold. For instance, in the UK, they apply a threshold of £30,000 per quality. What does it mean? Well, simple story. Imagine a new treatment for RA, and the cumulative cost of the treatment, because we were going to treat the patient for many years, will be £60,000. Let's pretend we are in England. England is a country at the west of Europe. It doesn't belong to Europe. It's not anymore. It's west of Europe. Yeah, it's their choice. They'll come back soon. No, not soon, but one day. £60,000. And we gain 3 qualities. So that comes down to £20,000 per quality, but I just said that the threshold is 30,000. So we are below the threshold. This is cost effective. This is a cost effective intervention. It's going to cost more money, but it's well spent money. But what we see nowadays is treatments that, for instance, cost £100,000, only deliver 0.5 qualities. That comes down to £200,000 per quality, and that's not a good result. We call this ratio the incremental cost effectiveness ratio. You can see it also here on this slide. So it's the ratio between the incremental cost and the incremental effect. And if that ratio is below the threshold, it's fine. If it's above the threshold, it's not fine. I have to admit, this is a little bit mechanical. It's like we can give the data to a computer and the computer says, okay, below the threshold, with a computer voice, below the threshold, and then said, fine. Above the threshold, bad, and that's it. It's not really making sense. It makes some sense, but we still feel uncomfortable. The WHO has said in 2016, cost-effectiveness information should be used alongside other considerations in a transparent decision-making process rather than in isolation based on a single threshold. We are not computers. There are more elements that should play a role in our decision making. And the 3 most important ones are, in my view, the medical need, the budget impact, and uncertainty. Medical need is a story inspired by an ethicist, Skitovsky, who says that there is something that we could call acceptable health level. Not perfect health, but acceptable. Okay, I still have some pain. Sometimes my left knee hurts, but I can do presentations, I can travel, so I have an acceptable level of health. I'm not perfectly healthy, but I acceptable level of health. And Skitovsky says, if you're above the acceptable level of health, that's comfort. We should not pay with our system for your treatment. You have some headache on a Monday morning, well, take paracetamol. And we are not covering it by the system. But if you're suffering a lot, you're way below the acceptable level of health, we have to help you, and we have to even pay more to gain qualities for those patients. To give you an idea, this was a paper by Mitchell et al. In December 2015. They used the Eurocall 5D, 5 dimensions, very easy questionnaire, just your mobility, self-care, usual activities, pain and discomfort, and then anxiety and depression, 5 dimensions. And on average, patients with arthritis only score a little bit more than 0.6. To give an example, asthma, cancer, depression is lower, diabetes, hearing loss. So arthritis is often underestimated in terms of severity. And this kind of data help to show this is a serious problem. In the Netherlands, they took it very literally. In the Netherlands, they published a couple of years ago, the official healthcare institute, who was responsible for health insurance in the Netherlands, they said, if the health burden to the patient is mild, our maximum willingness to pay for a QALY is 20,000 euros, which is much less than the 30,000 pounds of England. If the burden is moderate, our maximum willingness to pay is 50,000 for a QALY. If the burden of disease for the patient is very high, we are willing to go up to 80,000 euros per QALY. So the Netherlands have 3 different thresholds. For mild, moderate and severe disease, they have a different willingness to pay to gain QALYs, because the way of thinking is, if they suffer a lot, we want to do more for them, so we're willing to pay more to gain a QALY. But then there is another issue, namely the budget impact. Birch and Gaffney are 2 Canadian health economists, and they call the ICER not incremental cost effectiveness ratio, they call it information created to evade reality. And they are right, because if you only know the cost effectiveness of a drug, but you don't know the total financial impact on the system, then you're making a blind decision. So we need not only cost effectiveness studies to talk about efficiency, we also need budget impact studies to address the issue of affordability. It's a high responsibility also for the companies. The companies, when they say this new drug is for patients with rheumatoid arthritis, that's way too vague. They have to be much more specific. Which patients will be eligible for your drug? Do they first have to fail another drug? How many patients are we talking about? We need to describe them very clearly. And if needed, we are going even to an even more stratified subpopulation to make sure that we have a reasonable budget impact. So that's very important. And the final challenge is uncertainty. This is the payer, this is the industry, and the payer says, dear company, thank you very much, but you did a trial over 1 year. The trial is always a trial. Remember what Dr. Jamal said, it's an artificial situation, it's not the real world. We need more evidence that your drug is effective and cost effective. We are not going to pay you a blank check. And the industry says, yes, dear payer, but if you don't allow us to the healthcare system, we will never be able to show you in the real world how good we are. We have a catch-22. Well, we have to acknowledge indeed that there is a continuum between what we call efficacy on the left side and effectiveness on the right side. Efficacy means highly selected patient population compared to placebo, looking at an intermediate endpoint and very strict protocol instructions, artificial world. Effectiveness means that the patients are the real patients, the comparator is the most likely to be replaced, the real comparator, not a placebo. The relevant endpoints like quality of life, length of stay, readmissions, and the design is also closer to the routine follow-up of the patients. What we say is the trials that the companies are designing should get closer to effectiveness trials, not too artificial, but already more realistic. There is a second solution to deal with uncertainty, and that is contracts. And in Europe, several countries have now started with what we call outcomes-based agreements, not financial agreements. Financial agreements we all know, discounts, price volume agreements, sometimes that the first dose is free, etc. This is purely financial. Outcomes-based agreements means 2 things. I will show you the 2 possibilities. The first possibility, we call it the coverage upon evidence development. It means that the company gets the benefit of the doubt. Yes, your product is accepted, we will pay for it, it can be used. We launch the product, it's used in the real world, but we agree on a point of verification in the future. 1 year in the future, 2 years in the future, we have to agree on that now. And when your drug is not as good as promised, for instance, you claim that with your drug there will be less hospitalizations, there will be at least 45% patients in remission, defined by the DAS28, for instance. And then we will check at the point of verification whether your drug was as good as promised. If not as good as promised, then we will change the conditions of price and reimbursement of your drug. That is coverage upon evidence development. There is another type of contract which is now upcoming in Europe. It's performance-linked reimbursement. It means, again, we give you the benefit of the doubt, we follow the drug in the real world. If it's not as good as promised by the point of verification, the company needs to pay money back to our healthcare system. That's, of course, much more impacting the industry. Those are two new and I think very important trends. Of course, easy to say, but imagine you're a clinician, and many of you don't have to imagine, you are a clinician, and you have to fill in all this data to populate the registry, etc. It gives administrative burden. Another issue is, in the real world, the patients are more severe, have more comorbidities. How do we deal with that? We have to adjust our statistics to take into account. Sometimes the drugs are not prescribed in the right patients. Sometimes the patients are not compliant. Sometimes the data are of poor quality. And that's the last point, if a patient and a clinician know they are in a registry, it's not really real life. Because if a patient has to sign informed consent, dear patient, we want to collect information about you because we want to know whether you will be compliant, for instance, then the patient will know I'm in a study, even although it looks like real life, it's not really real life. So we have some issues here. In my view, the best possible way to deal with that would be to have a perfectly connected healthcare system. That means that every physician has all the time only a single input. Anything that you have to fill in for your medical record is filled in once. Automatically that is uploaded in the system. All the medical records are connected to one fantastic database, and then we can follow up all the data from routine medical practice. We don't have to set up any more new registries. Everything is collected routinely. That's the ideal world, of course. I cite Joris Halverson from Kaiser Permanente in California. They have such a system where all the patients have a medical record and all the medical records are connected to one big database, and they can follow up everything in routine practice. So, conclusions of my lecture. First of all, I point to the industry. There are some people from industry here. They have, of course, to make sure that their effectiveness studies and cost-effectiveness studies are 100% transparent. And they have to foster the cost-effective use of their drugs. It should be used in the patients where it is cost-effective use. They have to estimate the budget impact, and they have to do their best to keep the budget impact reasonable. And they have to, of course, as long as we don't have a perfect e-health system, they have to engage in those disease registries. For the payers among us, I think it's very important when we take decisions about reimbursing or not, that we are very transparent in our motivation. Why are we giving a positive advice or a negative advice? A negative advice could not be the price is too high. That cannot be a good motivation. It must be a full motivation looking at costs and qualities, budget impact, medical need, and all together we have to come then to an assessment and a conclusion. We have to also challenge current healthcare use. Within our current healthcare systems, there is a lot of non-cost-effective care. We have to identify that, and we have to recover that money and invest in new, more cost-effective things. And we have to also provide incentives for cost-effective care. What I mean by that is, if we can avoid readmissions, for instance, to the hospital. In some countries, a readmission to the hospital is an income for the hospital. It's not really making sense. If a hospital is not taking care well of a patient, and the patient needs to come back 10 days later because things were not going as desired, that should not be then an income for that hospital. There should be other financial incentives to make sure that hospitals gain when they can avoid readmissions. Maybe today is not the day to talk about that, but I wanted still to stress that. Finally, for the physicians, of course, the first responsibility is each individual patient, but physicians also should have a societal hat. What we are doing here, is that also good for society? Are we not making wrong choices for society? So we have to avoid non-cost-effective care. And maybe why not, in our clinical guidelines, also have health economic consideration. For all parties, we have to work much more together. Happy to see that this meeting has many stakeholders in the same room. That is perfect. We have also not to forget to invest much more in prevention. Better to prevent disease than wait until they are sick. And everybody should at least have basic knowledge about health economics. This is, of course, promotion for myself and also for my book, Health Economics for Non-Economists. It's a very cost-effective book.
How much?
I can make you a good deal. And I will conclude with a citation from John Lennon: everything will be okay in the end. If it's not okay, it's not the end. But it's the end of my lecture. Thank you very much.
Because we want to take a picture of that.
Oh,
Is it on Amazon?
not yet. The publisher is discussing with Amazon because Amazon wants to take too much money. Yeah. Because they have a monopoly. It's another discussion.
Amazon, of course.
Yeah, okay. But now back to John Lennon. Any questions right now? Is there time, Dr. Jamal, for questions? Yeah. Dr. Jamal is the moderator of this session. Yeah.
I mean, what you said is what you said about value-based medicine. It's already kind of he's nodding his head. He's in charge of it, doing it at a level like the readmission. I think you might take of it. DRG is diagnosis-related groups is reactive in 1st of April. So it's like people, if they come back to the hospital, they won't give the hospital the money.
Good. That's fantastic.
So this
Yeah.
is already on plan, moving on in the
Yeah.
as soon as possible.
That's fantastic. Even then, in Italy, they introduced that a couple of years ago. They said everything that happens within 30 days after the index admission will be at the risk of the hospital. But what happened there, but that's maybe typically Italy, I have to be careful. Once the measure was applied, there were many rehospitalizations after 31 days. Yeah, so the hospital told the patient, wait a little bit before you come back. And so there is always, yeah.
But there's equality-wise as well. There's governed by quality.
Exactly. What we have done in Belgium now, we did not yet apply the 30 days DRG, but we applied pay for quality. So hospitals with less readmissions, with less avoidable readmissions, get at the end of the year a quality bonus because they have performed better. So that's another way to, yeah.
Please go ahead.
So it's a question for you or for Dr. Jamal or for everybody. Do we have a threshold for the cost effectiveness here in UAE, for example?
Very good question.
I don't know.
I was about to ask him the question because I'm doing the study and it was entertaining and he's the expert. I was thinking, using the GPD in countries to compare countries like us, we don't have the infrastructure because what we're doing at the moment, we don't have the infrastructure. Comparing countries with GPD, using their data to mark our quality will be useful? Or?
Yes, but on the one hand, yes, because the idea is that, of course, if the GDP per capita of a country is higher, for instance, you have $40,000 per capita as GDP, and in Bulgaria, in Eastern Europe, they only have $8,000 per capita. It's normal that in Bulgaria they put their threshold lower than in a country where the GDP per capita is $40,000. That makes sense. But remember what the WHO said. They said, yes, you can do that, but please don't apply that as the only criterion. You have to take into account medical need and budget impact. Yeah.
Okay, this is. Mustafa, you had a question?
I think in Abu Dhabi they started to apply this rule of 30 days. But what I see in the medical department, they try to call the next admission as a different code. So they go.
This is fraud.
Yeah.
The medical department, I insist on the code.
I will not say anything about that, but I can just say that in my country the same things happen. So when a patient is discharged from the hospitals have to fill in the what we call the minimal clinical data set. So what was the primary diagnosis and the secondary diagnosis of this patient? And if that is inflated, the patient is then pretended to be more severe than the patient actually was. And then they get better financial conditions. So that means that there needs again to be a control system, because a large majority of people are honest, I still believe. But for those who are not so honest, we have to imply control systems to make sure that everybody follows the rules.
Information. This is. Muhammad remind me. There's a personalized number will be effective. That's if the patient in Abu Dhabi, for example, come and get a treatment from Dubai for the same cause of stuff identified, as well as with our colleagues in the private, we kind of have a one number that, I mean, there's a gap when I showed the admission. I don't know if they admitted to private because when you have that, so we have one between all of us, so it will be unified. So this is good for governing the.
No readmission.
Yes.
Readmission would be effective.
Yes, right.
If you have a network in Abu Dhabi and Dubai, and you would like to transfer your
We
patient
have-
to Miriam,
we
where
have-
you can.
Yeah, exactly.
Yeah, we're running late, so we.
We can start the next session.
Okay.
Thank you, Prof.
شكرا جزيلا. Yeah. Okay.
ما تفكرنيش بقى باللي احنا فيه.
Now moving to the next session. And as you see, the next session is titled Current Challenges in Achieving Remission.
Thank you.
Dr. Carter is presented by two eminent rheumatologists here in Dubai, Dr. Humaira Badsha and Dr. Bahar Khan. And I think they gathered together their efforts and they built some sort of registry by which they are extracting information. So I will welcome the first speaker. I think Dr. Humaira Badsha will be the first one to talk.
So thank you, Dr. Mustafa and everyone for being here today. So we, Dr. Bhavna and I have some data, and we're trying to put it in the setting of remission today. So where do we stand, and what are our current challenges in achieving remission? So first of all, I just wanted to present some old publications of mine. This is 10 years ago, where we actually collaborated with a group from Finland and many countries, 25 countries around the world, to look at how we compare in the Quest rheumatoid arthritis cohort, and that was 25 countries around the world. So this sort of like was looking at what Dr. Jamal referred to, high GDP countries and remission rates for rheumatoid arthritis. So we collaborated with our data. UAE is here in the center. Here you see the high GDP countries with high remission rates. About this is the ACR remission, and this is the DAS28 remission. So DAS28 remission, for instance, in places like USA is about 35%. In the UAE, this is old data, we were only at 20%, but this is more than 10 years ago, this data from. So at that time, we didn't have many biological drugs, we had very few rheumatologists, patients had a long delay in diagnosis, so there were many factors at that time influencing, and even in the private sector, most patients were not covered by universal health care like they are now. So the entry of insurance coverage has impacted a lot on how we treat rheumatoid arthritis. So currently, this was just last year, Bhavna and I collected data for a year. We have 573 patients between the both of us in our rheumatoid arthritis database. And here we have about 51% of our patients are in remission or low disease activity, and high disease activity is about 49, high to moderate disease activity is 49%, out of which 10% is high disease activity based on DAS28 scores. So what are the key factors in achieving remission? We all talk about remission so much, it's hard to achieve. As you can see here, our actual patients in remission is 36%. We'd really like that to be higher. We're doing a lot better than 10 years ago, of course, but we need to improve. So what are the key factors? So some of the studies have actually shown us that in the DAS28 score, the remission, you're aware that we have swollen joint count, tender joint count, patient assessment of their activity, patient's own global assessment, and an ESR score. So sometimes the patient global assessment is inflated due to many reasons like fibromyalgia, chronic pain, or they have joint damage. We actually collected some data with Loe. We have to look at what actions we take when a patient is not in DAS28 remission. And sometimes this DAS28 remission is not because the patient is not doing well, but they have chronic pain due to other reasons. So that should be actually taken into consideration. And many of the health authorities have stressed to us that even though that this patient
score may not be so valid. We really need to take the patient health or patient's assessment of themselves as a very key factor, because if the patient says they're not doing well, that means we're not doing well. So sometimes our DAS28 remission is skewed. So for patients, freedom from fatigue is the number one thing, and freedom from pain. So even though we talk so much about scores, we still need to be achieving this. I mean, we need to make sure that their global assessment of disease activity is fine. So one of the key factors driving remission is delay to diagnosis. And this study from 2017 and even many of our papers have shown a long delay to diagnosis. They've looked at 5,500 patients, and the lag time from onset of symptoms to seeing a doctor, any doctor, was 3 months. Then another 3 months from seeing a doctor to seeing a rheumatologist. Then there's another 3 months for diagnosis, another 3 months, so on and so forth. So this long delay to diagnosis actually affects your ability to be in remission. The shorter the patient sees a rheumatologist and gets on their first drug, the higher the probability of being remission. And this has shown that a DAS28 remission is very much influenced by how fast we get the patient and how fast we can see them. So on a societal basis, there's a lot we can do. Getting the patients in to see a rheumatologist faster and quicker will influence our ability to get the patient into remission. So we need to fast track them. I'm sure in advanced systems like Dubai Hospital, they have an ability to fast track patients who have rheumatoid arthritis into seeing a rheumatologist. In the UK, they have some systems like this. In private practice in UAE, it's quite easy to get in to see a rheumatologist. Patients self-refer all the time. They imagine they have rheumatoid sometimes. So we also collaborated with a large Middle East cohort, looking only at Arab patients in the UAE and Arab patients across the Middle East. This has been published. So just to show you that our methotrexate use is quite high. 77% of patients with rheumatoid arthritis are on methotrexate or have been tried on it, and that's comparable to the region overall. So we are not using less methotrexate. 29%, and this was not just my Arab patients, it was also from the government sector and Al Quwain and other Arab patients across the UAE who participated. This was from a genetic analysis of the genetics of rheumatoid arthritis. It was published in Nature, where we actually looked at the genetics of RA in Arab patients and how it differed from Caucasian patients. So with that, we got clinical data. So in the UAE, 30% of the Arab patients were on biological drugs, as compared to 10% in Jordan, which was low because they don't have that many third-party payers, and 47% in Kingdom of Saudi Arabia. So, we are not the highest, we are not the lowest, so we are doing okay, I think. So, what are the barriers? This again is a little bit of an older paper which I published with a student, where we actually looked at barriers to achieving disease remission in the UAE. There we looked only at 182 consecutive patients, and again there 47% were in moderate to high disease activity, and most of it was because they were failing methotrexate, or the patient themselves didn't want to take drugs. 17% of our patients didn't want to take drugs, so patient education could do a lot. Some patients were failing biological drugs and needed to switch, and Bhavna will cover that part, or they not had enough time to get better. Safety concerns, comorbidities, there was also one where they were unable to afford, which came under other. So one of the factors which we looked, which the physician listed, is inability to afford biological drugs. 16% of patients, either their insurance didn't cover them, or they were not able to afford biological drugs, and that was a reason for not being in disease remission. So this is a large study looking at 82,450 patients, and they looked at what actually are the remission rates in the real world. 24-month remission rates are only 23% in the real world, which is looking at multiple studies around the world. So 23%, that's quite low. So in the UAE, I think we're doing quite well in our database if you're saying 37% of our patients are in disease remission. So I just wanted to give you some data from our database. How can we improve certain characteristics, patient characteristics, to achieve remission? First of all, most of the patients who were in remission were able to work full-time or part-time. And patients who were not in remission could not work. That was statistically significant, and we know that. That's a societal cost. So patients who were in remission were much more likely to be working full-time. Very important. Female patients were less likely to be in remission. So we have to look at that more closely and see why were the female patients less likely to be in remission, and that was statistically significant. Patients love to try Ayurvedic, homeopathic, and all sorts of other alternative treatments. We looked at that. Is there a delay to diagnosis? So we asked the patient, did you delay your treatment with conventional medicine because you took all these drugs? So it was a patient-reported outcome. They may be lying. We could not achieve statistical significance in this question, but the patients who said yes and who were in low disease activity, only 28% of the patients in the remission or low disease activity, 19% of patients in the remission or low disease activity delayed their treatment versus 33%. So almost double of the patients who were in moderate to high disease activity had delayed their treatment because they were taking Ayurvedic or alternative treatments. This was not statistically significant, but numerically big difference, 33% versus 19%. So I think that if we can educate our patients better, get them to see the rheumatologist better, convince them to take methotrexate and not to go to conventional, because in this place the cultural things, a lot of South Asians living here, lots of other things, and they're doing all sorts of alternative therapies, and all of us have those experience with the patient who did not take methotrexate, went to Ayurvedic and came back with damaged joints. So it's a very sad thing which we can avoid. Also smoking. Again, this was not statistically significant, but if you look at current smoking, the patients who were in low disease activity were much less likely to be current smokers. Body mass index, this was statistically significant, even a small loss of weight. So the BMI of people who were in low or remission was 26 and 27 BMI, versus patients who were in high or moderate high disease activity was more. And that was statistically significant. So also there was a long lag time, again not statistically significant, but we see that patients who were in high or moderate disease activity had a lag time between date of first joint symptoms and diagnosis of 2 years. So the longer your lag time to diagnosis, the more likely you're to be in high disease activity. Again, our numbers are small. As we expand our numbers, I hope to show statistical significance. So we compared patients with methotrexate and biologicals. We're not seeing a difference because the patients who were on biologicals also happened to be on methotrexate. So we're not able to show a difference, but we're going to do a multivariate analysis on our group. But in our previous data, we were able to show on the multivariate analysis that the best predictor of being in low disease activity or in remission was a biological drug. So it's expensive, but that was the best predictor. Let me know this. So that was about remission, and I'm going to...
Thanks a lot, Humaira. I think that was a very interesting presentation and a plausible effort to collect these local data. And I think now Dr. Bahar Nahan will continue the same session.
Thank you. So good morning, afternoon, everyone. So I'm just going to focus on the other aspect of what Dr. Humaira was presenting. So it's the same population of patients that we've seen from our cohort. But what I'm going to address is the day-to-day challenges we're facing, which is more relevant to our local population in our clinic setting. So just for the benefit of our colleagues from insurance departments, we have, over the last 2 decades, expanded our armamentariums in treating patients with rheumatoid arthritis. There have been huge advances, and no doubt that biologicals have changed the outcome of rheumatoid arthritis patients. When we were trainees, we used to see patients coming in a wheelchair to the clinics, but now hardly anybody comes to clinics on a wheelchair. And admission rates have definitely come down. So on the other side, you see the conventional DMARDs, methotrexate, leflunomide, sulfasalazine. Interestingly, we are still using hydroxychloroquine, and the setting we use is in patients who are really in low disease activity or patients who want to get pregnant. The women, it's a safer drug. And also when we're stepping down the treatment, I think that's one of the aspects which many of us didn't touch base today, but we do attempt to step down the treatment in patients who actually achieve remission and remain in sustained remission, and hydroxychloroquine is one of the drugs. And on the other hand, we have the biological drugs. The list is expanding, and we have many more to come. So the first ever biological drugs are anti-TNF agents, followed by the non-TNF biologicals, and we have recent addition of JAK inhibitors. So the list is growing, and hopefully we will get better outcomes in these. However, when it comes to the patients in our local population, I'm going to talk only about the private sector, because we must understand that there are some differences between the patients we see in our clinics versus what Jamal was presenting earlier. We in private practice see mostly expatriate population, and these are, remember, the working people who come from another country to make their living here. So their health, their well-being is really important to have the healthcare access. I think that is something we need to understand, because a patient who has disability because of rheumatoid arthritis cannot simply continue his work, and he has to go back to his country. So there is a huge pressure to get these people in quick remission and sustain the remission on the private sector. Also, there might be some bias, because the clinics that we have, we only accept insurance policies which are either CN or GN network. So we do not really see a lot of these patients with basic networks where they don't have access to the drugs. So in 2 slides, I'm going to just quickly summarize the challenges of conventional DMARDs and the biologic DMARDs. Of course, we are happy that we have biologic DMARDs, but we do have challenges even with these drugs. So what are the common challenges with the conventional DMARDs? Clearly, it is slow in onset of action. We need to wait for about 8 to 12 weeks for these patients to start feeling better. Methotrexate is still considered as our gold standard, and all physicians and payers love it, but the patients absolutely hate it. So that is the reality. And we have also these patients need frequent lab monitoring. You need to have monthly monitoring initially as per our RA guidelines approved by the DHA and also the international guidelines. We still have challenged patients coming on time for regular blood tests, and also sometimes we do have challenges from the payers as well. They just reject the test saying frequent monitoring. And I think, again, I want to make that point that please refer to the guidelines. These patients initially need regular monitoring. Of course, that's a setback. And efficacy is only in about 30% of these patients. We've seen that data earlier as well, that most of the patients have efficacy of only 30% with conventional DMARDs. And of course, poor adherence and compliance. There's no way we can track these patients and say whether they're really taking it or not. They're not always very honest about it. And adverse effects, so we'll see in subsequent slides, the adverse effects associated with conventional DMARDs, which can be a setback to our patients. Comorbidities, like patients who have underlying liver disease or renal disease, sometimes we are not able to use the conventional DMARDs like methotrexate and leflunomide. And one of the biggest challenges we have is the bridging treatment with steroids. Patients in this part of the world just absolutely hate taking steroids. But you have to wait for 3 months to get effect on methotrexate and other conventional DMARDs, and steroids are still used as the bridging treatment. We also know that the infection rate is much higher in patients who take concomitant steroids along with biologics or conventional DMARDs. So this can be a major challenge in clinical practice. And of course, concomitant treatment with NSAIDs. We know some of the drugs like methotrexate, leflunomide, along with NSAIDs can have a higher risk of hepatotoxicity and renal toxicity. Now coming to the challenges of biological DMARDs, of course, these are breakthrough treatments in our field. However, cost is a major issue, which we've discussed and in all the previous talks. And route of administration. In some patients, this can be a benefit, but in some patients, this can be a problem. We have a lot of our patients in private practice who are doing a lot of business travels. They are traveling all the time, and they have to carry these drugs with them, and it is a challenge. But on the other hand, some patients who are not compliant, this could be a better way of actually measuring their compliance. Many of our patients still want to come to the clinic to administer these drugs, so that's how we know whether they are actually compliant or not. And of course, there can be a poor adherence and compliance. Drug survival is the main issue, because we know, in some of the subsequent slides I'll cover that despite having huge number of advances in the number of biologic drugs, the survival of the drug is still a major challenge. Most of these patients need switching of the biologics over time. Comorbidities, sometimes patients with pre-existing or rheumatoid-associated lung diseases may not be eligible for anti-TNF agents, and likewise other pre-existing conditions and comorbidities can be a hindrance. adverse effects. We're all very much worried and concerned about long-term safety and adverse effects of biologics, particularly chronic and opportunistic infections like TB and hepatitis, and pregnancy. Although we have some drugs which can be used until a certain period of pregnancy, we still do not know the long-term implications of these biologics given to pregnant women, although they need these to control the disease activity, but we don't know the long-term effect on their babies. So, in rheumatoid arthritis, we have three major therapeutic misses, which is therapeutic delay. So, as Dr. Mehra mentioned, we still have a major challenge of delay in diagnosis and delay in initiating treatment. And we have DMARDS dropouts, and I'll show in subsequent slides that nearly 40 to 50% of patients do drop out their DMARDs at the end of 3 years. We know rheumatoid is a long-term disease, so patients basically develop this in their 20s or 30s, and they have to live with this disease for nearly 30, 40 years. So if every 3 years you're going to lose a drug, so you only have about 9 years to cover with these conventional DMARDs. And of course, in clinical trials, we always talk about efficacy rates, achievement of ACR 20, 50, and 70. But if you carefully look at that, you also have about 30% of biologic patients who do not achieve remission. We have nearly 60 to 70% of patients on methotrexate or a control drug who do not achieve remission. So the numbers are still very high. So just to give a comparison, so these are some of the early pivotal studies on anti-TNF agents. If you look at the methotrexate in the placebo arm, the numbers are very small. So again, in the next slide, I'm going to talk about the Corona registry, which Dr. Jamal and others have referred to, but it's a different aspect of it. So what we're looking at in this slide is basically the number of patients in the Corona registry who received methotrexate as a monotherapy or as a part of combination therapy. So nearly out of about 6,000, approximately 6,000 patients, 1,488 patients received or initiated methotrexate monotherapy, and nearly 650 patients initiated methotrexate in combination with other DMARDs, conventional DMARDs. This is a very long real-world data from 2000 to 2017, and what we look at is methotrexate monotherapy discontinuation was nearly 1/4 of the patients at the end of 1 year discontinued that, and the number increased to 1/3 of the patients and half the patients at the end of 3 years. And these numbers were not different when methotrexate was used as a combination of treatments. So nearly 50% of our patients cannot sustain only conventional DMARDs at the end of 3 years. And when we looked at the reasons for discontinuation, so there were basically two reasons. One, either it was a physician's decision to discontinue or patient decision. When we look at all the patients who discontinued methotrexate because of physician's decision, 85% of them were because of infections. So we are worried about biologics-related infections, but actually in real term, patients on conventional DMARDs can also have serious infections. And about 15% of them were associated malignancies. So skin cancers, etc., are quite common in methotrexate group of patients. Now, when you look at the patient decision, when patients decided to stop methotrexate, it's very interesting. I think in the previous slide we saw Dr. Mehra mentioning about fatigue, rheumatoid arthritis-associated fatigue. But if you look at it, methotrexate, one of the major adverse effects where patients decided to discontinue methotrexate was fatigue. In about 70%, that's 3/4 of our patients experience fatigue. And sometimes they come and ask us this question: what's the point in getting our rheumatoid arthritis in remission, but I'm still fatigued? I'm not able to work. So we talked about the absenteeism, presenteeism. I think what is more dangerous is probably presenteeism, because it's obscuring your health economics, because the patients are actually working. Important thing. GI intolerance, 50%. And hair loss. I'm sure all women in this room will agree that hair loss is a big deal for our female patients, and they do not want to take methotrexate when they have hair loss. I'm sure even for men, but certainly our female patients do not want to continue methotrexate because of that. So, now what about the biologic drugs? Of course, conventional DMARDs, 50% of them discontinue at the end of 3 years. What is the challenge we have with biologic DMARDs? So this article was basically a systematic review and meta-analysis of all the studies where they looked at discontinuation rate of biologic treatments as well as the drug survival. At this point, there were no JAK inhibitors were not included in that. They mainly looked at anti-TNF agents and the non-TNF biologics, that is abatacept and tocilizumab, as well as rituximab. Now, I'm not going to go into the detail of the study, but if you look at discontinuation rate of biologics at the end of 12 months in all biologic groups, again, nearly 1/4 of them at the end of 12 months had to stop biologics. And if you look into the more details, the anti-TNF groups, at the end of 4 years, half of them had discontinued their anti-TNF agent. And individually, when you look at it, etanercept seemed to have a slightly better survival. I mean, this was clinically significant, not significant, but etanercept seemed to have a better, slightly better drug survival compared to adalimumab and infliximab. And this is because of the immunogenicity associated with the other two molecules. So that, in summary, tells us that the worldwide problem still remains the same and the challenges are pretty similar. Now, looking at our patient profile, our patient cohorts, which Dr. Mehra briefly covered on some aspects of that, at the time of publishing this was an abstract we published. We included 519 patients with rheumatoid arthritis. And we looked at their DMARDs as well as biologics therapy. So at that time, we had about 486, so nearly 94% of patients had received conventional DMARDs. And 6%, only a small number of patients were not on conventional DMARDs, so you can see that in this graph. Now, if you look at the other side, where the split of the drugs, so we still have methotrexate. So we still have, amongst the users, we still have methotrexate as one of the leading conventional DMARDs, followed by the other drugs. So you can see that on that. So that reflects there again. So again, when we looked at the active versus discontinuation of conventional DMARD patients, across all the conventional DMARDs, nearly half of them continued and half of them discontinued. So that's exactly what it shows. And looking at the reasons for discontinuation of conventional DMARDs, what you can see is most of the methotrexate, the pink ones here, the side effects was predominant cause of discontinuation, followed by the secondary loss of efficacy, so this group. Again, that reflects what I showed earlier and is very consistent with the real-world data from other countries as well. Now, when we looked at the reasons for discontinuation of biological DMARDs, probably the next table will show it better. So we have 3 groups here, so methotrexate and the biologic DMARDs and JAK inhibitors, so the target, the small molecules. 53% of patients, that is half of them, discontinued methotrexate. There was no statistical difference between the discontinuation rate of biological DMARDs as well as JAK inhibitors. When you look at the causes or the reasons for discontinuation, again, side effect was more common cause in methotrexate group, followed by secondary loss of efficacy. But when you look at the biological DMARDs, secondary loss of efficacy was the leading cause, followed by primary loss of efficacy, and then patient choice, and followed by remission. So we have 10% of these patients actually went in remission where we actually discontinued biologics. So I think that's again an important point, that rheumatoid arthritis management is just not a static phase. You have ups and downs. So we do need to address their treatment when required, but when they are in long-term remission, you need to, we do taper the medication. So in conclusion, we still have a lot of unmet needs despite all the advances in this field. We have patients who present late and have delay in the onset of treatment. But what is more challenging is we still do not have predictors of or the patient profiling or strategies to sort of tailor the treatment for each individual patient. Although we understand the molecular aspect of the pathology, but we still do not have paradigms where we can actually slot the patients according to their molecular profile. And there's still no consensus on the combination treatment. So we know that methotrexate is a gold standard, and all clinical trials use methotrexate. But what is the best combination of a biologic and a DMARD? Or what is the best combination of a DMARD and a DMARD? There are no clear studies on that. So safety concerns remain in both groups of patients. And I think what is really undermined in this local region is the social and physical impact due to disability, because there is no one to pay for their disability and their social well-being, because half the patients are depressed, and they need to see psychiatrists, they need counseling, they need psychologists, but nobody to pay for it. And patients, and actually, they are the most expensive costs actually. The psychologists and the psychiatrists consultation charges are really not affordable. And when patients have disability, orthotics, many of the policies don't cover orthotics, and patients are not happy to pay from their pocket. So I think there are still a large unmet needs, maybe slightly different from the worldwide problems, but we do have similar challenges in the local practice. Thank you very much. Not sure if we have time for the questions.
If it's not time, a few minutes, I think.
10 minutes.
You can have 5 minutes.
5 minutes, okay?
Okay.
I think we need some questions from the payer side. I think they've been very quiet since morning.
Payers have to ask questions.
Yes, I think this is meant for you guys.
They're going to ask you a question otherwise.
No, payers are.
I think one of the controversial and interesting things from our data is that 10% of our patients were able to stop biologicals due to prolonged remission. This is controversial from evidence-based medicine because you're not really supposed to discontinue biologicals, but patients do discontinue for pregnancy or because they're in prolonged remission, they say, okay, now I want to stop and get pregnant. So I think that's an interesting point.
Thank you, both of you. I would love this information. The data from America say within a few years, 80% might well flare again. And that's what interval.
Yeah, we're very aware.
But the Europeans say, let's save costs on the 20% who might not have flare. And that's where the...
I think the interesting point on that would be that it's we need to look at the patients who started biologics very early and went on to long-term remission versus patients who started biologics late and then look at the number of flares in that. I'm pretty sure that the ones who started late would have or they need longer duration of biologic treatment. Any more?
I think we are happy as rheumatologists that the insurance companies still accept our DAS28 as a measure. Actually, this is something in favor because we know that also with DAS28, still, even people in remission, they can still have some low inflammatory process. So I think part of our discussion here, although we already talked about the CDI, SDI, whether to continue with DAS28, and this is the way we communicate to the insurance, to the payers, our reflection of the patient status. So I think we all agree
We would
with that.
like to hear from the payers.
Yeah, I think there's a question here.
Can we before proceeding with this actually, because this is it's a sort of a triple meeting. It's between the health providers and the payers and the industry. So we think we have to be more acquainted with the payers. So is it possible for the payers to introduce themselves to us so that we can know that?
There's a question here.
The question? Okay, after the question.
If the patient on biologic DMARS and he stays in remission, so when can we consider to start tapering, for example? For how many years?
I do not think there is a set time. So the way clinically, because there are again no clear guidelines as to how to step down the treatment, it's very much an individual patient and a physician assessment reliant. So when we know that the patients have been on a stable disease activity, we try to taper depending on which biologic. So for instance, if they're on an anti-TNF agent, you simply either prolong the gap between the two. Also, we educate the patients that if you do start flaring up, you don't need to continue to wait until you see the doctor next. So I think it's very variable. So, and also I think the other challenge which I didn't mention here is patients here do not remain with one payer all the time. So you may not have the history of the patient from the previous payer. So I think that poses a major challenge because if you've got a new patient on board and we start tapering the medicine and if they flare, they go back, you do not really know how long they've had a disease. So I think at some point you need to rely on the physician's judgment and recommendations. I mean, that's my point, but
Yeah, I mean, I think I would like to, as the previous professor mentioned, that like to reduce the burden on society, first of all, and third-party payers. I really personally don't believe that we should keep putting people on biologicals and leaving them on it forever. So if a patient is stable and in long-term remission, I attempt to taper by prolonging the gap between, and it's not only for society, it's also for the patient's good. If they can be on lower drug with a less suppressed immune system, especially in this time, all patients with coronavirus are very keen to taper. Yes, doctor, if it's good for my immune system, I'll taper. So, I mean, trying to prolong the gap between the injections. That's what we do first, and then we kind of try. I mean, I have patients who have reached even etanercept once a month, you know, and they're stable for a long time. The data does show, as Dr. Atir says, when we stop, they do flare, a majority will flare. So mostly I try to keep them on the lowest minimal dose and then continue like that. So that's my practice. Very, very rarely will I discontinue because the lowest minimal dose seems to be effective.
Yeah, but also I would like to make a point that it may appear that we want to prescribe drugs to patients, but trust us that it's a major challenge to get a patient to go on a biologic. And no patient want to take a medication unless they really are in need of it. And also, yeah, exactly.
Data shows that the majority are
not willing to take it, but on biologics as well. But also the other point is, it's not a one decision. So you've got to keep, adjusting the treatment, and this is what our ICORA study showed, that every 3 months you evaluate the patient. If they've been in remission, step down. If they are in flare-up, then you step up the treatment. So
if we have a clear pathway with consensus between all dermatologists and we share it with the payers, I think they will not have any problem. The main issue is the individualization in management, because not all patients are the same. So we should have a matter of trust between healthcare providers and payers. And over time, when you build this relationship and you have the payers, they know that Dr. Humera or Dr. Bhavna, when she give a report, they know that you are doing the right thing ethically. There will be no problem from the insurance side, and we can guarantee that as a regulator.
But also it's like sometimes the variability comes from when she sees Dr. Bhavna, that patient is in major disease activity.
Yes.
2 weeks later, she comes to me for a second opinion. Somehow she took steroids or whatever, and she's fine. She's in disease remission now. So Dr. Bhavna has seen her 2-3 times in major disease activity, has prescribed a biological. Now she comes to me in a month later and she's in remission. So I have to trust my colleague's judgment that she's seen her 3 times. And you know, like when we get second opinions like that and then suddenly they're in remission, I don't like to go against, I mean, unless I then have the opportunity to see this patient 2 or 3 times. But just seeing them once in remission, say, oh, you don't need it, it's a bit tough. You know,
Actually, again, sorry, Dr. Through the DHA and Dr. Jamal, we agree on second opinion. If the payers, they need a second opinion, there will be like a task force or committee, and Dr. Jamal is there. So we will agree on who will decide about second opinion. Between you again, you can decide. So they know the pathway. Once there is, they need a second opinion, they will send to us, and we will send to second opinion assigned persons.
I think I totally agree with that. I think we should probably encourage that, because then the payers are convinced that yes, this patient has been evaluated by 2 independent rheumatologists and the patient actually needs it. But also I think one other point I would like to make is there can be a variation in our practice. For instance, most of the patients that we see these days are either a second or a third or a fourth opinion, and they've had a long-standing disease. And they often come with having tried several DMARDs already before. So I think that should not really reflect, an individual clinic's performance, but it's the type of patients we see. I think that makes a difference as well. But I agree with you, Dr. Furghani.
Upon all the points you touch on for the payers, I have a scenario that the insurance asks me, what is your treatment plan and what is the cost of the medicine? This is a point need to be understood very well. This is a chronic disease. There is no course of 6 months or 12 months. Similarly, some rheumatologists tell patients, you will take the course for 12 months, and they come to me, when should I finish this one? That's really put me in a very difficult situation. Chronic disease means just like diabetes. I keep explaining it. It's just like diabetes in for a long term. Turns on when you're tapering, there is a study. They try to taper at 6 months or 12 months or 18 or 2 years. Obviously, the 2 years did better than all these categories. Still not perfect. What I do when I start tapering, I adopt, this is my own way, the epilepsy rules. You need to be free from seizure for 2 years before you taper. I say you need to be free from any flare or any problem before I start tapering. Otherwise, any flare indicates your disease will flare quickly.
Yeah, I think, and we also can do this like, we also employ ultrasound in our clinics. So I never taper till I'm also convinced of ultrasound remission. And I do an ultrasound on all my patients. I don't charge, but I do it on all patients as a bedside tool. It's for me part of my examination. So deep remission, which is what Dr. Athir is referring to, deep remission or Boolean remission, where there's no swollen joints, no tender joints, no ultrasound evidence, the patient is in deep remission. I think that's when I feel comfortable with treatment. But lots of patients can achieve it. The faster we treat, the faster we can achieve it.
So, yeah, they can, but I'm scared that some people will need to go to the mosque for the prayer. So there is an exercise for Dr. Mustafa Aizi specifically. Once we are back after lunch, we'll be back here by 1:45. Let's be, because I know it will take like 15 minutes for people to come back. So the lunch is at 7th floor at V Hotel.
Thank you. Thank you.
In Hilton lobby. You'll find the directions to the lunch. It's at 7th. Presenting some slides. Don't worry, there is someone assigned for the. So, Alisa, can you hear me? Okay, so thank you everyone for doing this live broadcast, and allow me to give special thanks to Alisa, because actually it's like 3 a.m. or 4 a.m. there in US, in her time zone. So thank you so much for accommodating this request, really highly appreciated. So Alisa is the president of Train for Change Incorporation, and also she's having a PhD in clinical psychology, and also she has a wide experience and practice in implementation of behavioral change strategies. So this session will be an interaction, and it will be sharing some slides, so I will not ruin the full let's say, actions that will take place during this session. So, Alisa, the floor is yours.
Oh, well, thank you so much. It's wonderful to be here with all of you, even if we are here at the end of the day and I'm at the beginning of the day. I'm really excited to share with you some of the content that we've worked on, and hopefully there will be a few takeaways. So really this session is designed to be very interactive, to give you just a few tools that will. So I'm going to go ahead and share my screen so that you can see the slides. Okay, if you can just confirm that you can see those.
Yes, Alisa, yes, you can go ahead.
Okay, wonderful. So we're going to be talking about 4 main skills, and these are ones that really rise to the top in the literature as the ones that can help with adherence the most. And I think the thing that we struggle with a lot is that you do such a nice job of giving your patients the rationale, the reasons why they should take their medication as prescribed. But then, and they seem to understand it, and they nod and smile while they're in the office, and then when they go back home, things start to creep in, whether that's them reading information online or deciding that maybe they should take it in a different way than prescribed, or they, for some reason, forgot the information that was given during the visit. And so these are designed to help with that, to make sure that the information that you are giving them really resonates and is understood by them, and gives them some behavioral skills that you can work on directly with your patients to help maintain that adherence over time. So the flow for this is going to be that we'll go through, I'll do a very brief didactic on what each of these skills are, and one at a time, and then I will have you demonstrate. So I'll ask for 2 people to come up, and Miriam, I think, will help me with that, and we'll get you to practice this. And remember that this is a learning environment, so it's okay to make mistakes or not understand it, and we can work through that, and hopefully then you'll leave with some of these skills feeling confident and able to use these with your patients. Sound okay?
Sure.
Okay, so let's start with elevating listening skills, and I think this is something that I'm having a hard time advancing this. Let me see what's going on. Not sure why it's not moving. 1 minute. Oh, there we go. So when we think about elevating listening skills, really we often put that in that soft skills category, that, okay, yes, we should be more warm and we should make eye contact, or perhaps we should be silent a little more, and so that the person has a chance to speak, knowing that that can allow someone to open up some more. But the type of skill that I'm going to be talking about right now is more of this active listening skill that is something that is that is called reflective listening. So I want to start by talking about this natural human tendency we have as helpers to tell people what to do. And we call this in motivational interviewing the righting reflex. And that response is our natural response within us as helpers to want to fix what we see that seems to be a problem with someone, or that we want to make that change happen, that we feel that sense of urgency for that patient. And because of that, we feel that inside of us. It's that uncomfortable feeling that when a patient's telling us, I don't know if I want to do this, or I'm not sure if I want to do this, or I'm not ready to do this, and we see that this disease is impacting their life, that we want to jump in and set them straight. We want to tell them why this is important and why they should do something. But the responses that patients have to that kind of response when they're not quite ready falls into three main categories. One of those categories is that they feel pretty invalidated. Someone can feel like, this person's not listening to me. I'm not being heard in some way. They can also feel very somewhat angry or oppositional. So that comes out as more of that energy that you might hear in an interaction, where they are cutting you off and talking over you. They seem to be more defensive in the way that they're interacting. And then that third response is that they become pretty passive. And from a behavior change perspective, the passive part can be the most worrisome, because sometimes it can sound like they're agreeing, or they kind of slump down in their chair and say, yeah, that's fine, or yeah, I'll do that. And so we're getting the verbal responses of, yes, they'll do this, but we can tell that they've stopped engaging in that way. And so when we think about that righting reflex, that desire to fix, that can really get in the way of our own ability to listen. And so that's when reflective listening comes in. How many of you have heard of reflective listening before?
No.
Yes, okay. So this is really the skill of accurate empathy, and it's my favorite skill to teach, because it is something that is pretty small and easy to do, but that can really transform the way that interactions happen. And it's when you read in the literature how important empathy is in interacting with patients, this skill of reflective listening is the skill of accurate empathy. So it makes it something that is a behavioral skill that you can learn and you can practice and get better at. And we know that this impacts patient outcomes. We know that there's a direct relationship to health outcomes when it comes to just doing this skill of reflective listening. So the challenge with reflective listening, though, is that it is a little harder than just what we want to do, which is tell the person what to do or ask questions. A reflection is really a hypothesis, so it's phrased in that where you're making a guess about something, but you're ending that statement with a period. You're ending it in a way that your voice comes down at the end to make that a statement rather than a question. So if a patient was saying, let's say that this little interaction that you see on the screen, the patient tells you, I'm getting really discouraged because it feels like people minimize what I'm going through. What might be a statement that you could offer that would capture what the meaning is of what that person is saying? And so it's maybe not exactly what was spoken, but it's if you're understanding that and thinking about what could that mean and then offering that back as a statement, what might that sound like? Anyone willing to try?
So we could say something like, is it on?
Yeah, it's working.
So we could say something like, so you feel people don't understand, so it may be that people don't really understand or know what is happening with you.
Yes, yes, exactly. And do you see, that's beautiful. And do you see how that really allows that person to be validated in that and then continue exploring? And I think that one of the most beautiful things about a reflective listening statement is that even if we're wrong, it allows someone to continue exploring. So if the patient heard that reflection and then thought, no, that's not exactly it, they can say, no, it's not really that. But then what they tend to do is then tell you exactly what they did mean from that. And that's a really nice way of encouraging that person to feel like they have that space to continue to explore. And to do that in a way that doesn't have that, what can sometimes be considered a threatening or defensive response from question asking. So if you said, why are you discouraged? Or you don't think people know what you're going through? Why do you think that might have that defensive response from a patient?
It sounds attacking.
It does, doesn't it? It even though you're asking it perhaps with that intent of, I'm really trying to understand, or, oh, why wouldn't people know what you're going through? Or, why are you feeling that way? It makes someone feel a little bit like, yikes, I need to step back from that, and maybe that's not a safe place for me to talk about this with this person. But the reflective listening statement allows someone to feel understood and to continue exploring that with you. So this is something that doesn't have to take a lot of time. I think when talking with physicians, of course, one of the challenges is that your time is valuable, and you have lots of patients to see, lots of other obligations in addition to seeing patients. And so sometimes people can say, I don't have time to listen to patients or to go down this path. But there have been lots of studies around this showing that even just 2 or 3 minutes of this kind of listening can significantly impact the way that patients perceive how long you actually spent with them. So that when they're asked at a later date, how long did your provider spend with you, they tend to estimate that the provider spent a lot more time, sometimes even double the amount of time, just because they perceived that interaction to be something that was more impactful. And then the other impact that I think is really telling for reflective listening is that the patient satisfaction scores tend to improve significantly when that few minutes of reflective listening are used.
Can I ask a question?
Please, go ahead.
Because as physicians, our normal reflex when a patient says something like that would be to say, I mean, we may not ask them a question back, but we may say, tell me about it, tell me more about it. But that's not really reflective listening. But I think most of us will say, okay, why didn't you tell me about it, or something like that.
Exactly.
So, but that's
and I
not
think tell me about it is a really nice, oh, I'm sorry, did I cut you off?
No, I mean, I'm just asking
Okay.
the difference between tell me about it, which we would normally use, versus this reflective listening, I mean, which would be a little bit different from what we used to, so we'll have to think about this reflective listening question a lot more.
Yes, absolutely. So it works really nicely when you're using it with that kind of question, like a tell me question. So if somebody said, let's just use this same example. I'm getting really discouraged because I feel like people minimize what I'm going through. You could say, tell me a little more about that, which is a really nice open question and is still part of great communication skills. Now, as the patient starts to open up more, the reflective listening can be used with the question asking to allow the person to feel like the narrative or the meaning that they're giving to that is being connected to the meaning that you're understanding. So if you tried tell me a little more about that, and then the patient said, well, I just feel like everyone kind of rolls their eyes and says, oh gosh, you're in pain again. Yes, we've heard that. We all have aches and pains, something like that. Then a statement of listening would be to just repeat or to summarize what you've heard that person say. So it's allowing you to go beyond exploring that more and really trying to show that you understand what that person is saying. So it doesn't have to be that everything that comes out of your mouth is a reflective listening statement, or that you're replacing all of the tell me more about that with reflective listening. It's that somewhere in that exchange, you are offering maybe just one statement to show that you get what that person is expressing, and that it's going beyond just I see, or okay, I understand. Those kind of statements don't really connect with what that you're actually understanding the meaning behind that. So backing back up, if the exchange was, I'm getting really discouraged because I feel like people minimize what I'm going through, and you said, okay, tell me more about that. And then the patient said, well, I just think every time I say I'm in so much pain, my family rolls their eyes, and then they say, we all have aches and pains as we get older. That's just part of aging. To then offer a reflective statement there and say, it's hard because there's really something going on with you that is that's different than normal aches and pains. What you're trying to do is connect that with that person to make them feel like, yes, you really get it. It's going beyond just okay, I get it, but actually using your words to show that you understand and that you can see it from their point of view. Does that help explain and answer that question?
Yeah, I think if I may ask something.
Of course.
Yeah, I mean, as clinicians, we, especially in rheumatology, we see patients with chronic pain and a lot of symptoms. So we, over a period of time, learn a balance as to how much to listen and when to stop the patients. And especially in a few patients who have fibromyalgia, you just let them talk, and you would probably end up seeing that same one patient throughout the day. Also, medical students are now being taught as to, as a part of their history taking, how much to lead the patient to talk to you and how much to intervene and stop them. So I think it's a balance that we learn over a period of time. So it's just a comment, because I understand the reflective listening. You want the patient to feel that you're listening to their problems, but at the same time, you need to have that art of intervening or interrupting their conversation and taking over the conversation.
Can I add something?
Yeah.
Following
You're absolutely right.
Well, following the line, and again, the same person which you allow for listening. I mean, of course, you won't do the reflective listening to all patients. There's a subset of patients that had a concern. You need to focus on them. Correct me if I'm wrong. The reflective listening in a setting of busy clinic. There will be certain people to target for reflective or effective listening, in a sense. Now, cutting these patients, you're reflectively listening to the patient, but episode will come that you have to rush the patient. Would that be taken wrongly by the patient side, from the patient side? You getting where you got what?
Jumping in at the right time. How do we do that?
What I'm trying to say is the patient who are you already given the time, you reflected and you carried on his issue, concern. There will be an episode that you might, during the course of this consultation or subsequent consultation, you might cut him off because not all days allows for more than 15 minutes for consultation or 25 minutes for consultation. Do you have any data on that supporting that it won't fire back on the doctor-patient relationship in the future? Because I've seen that as a complaint. I've seen this as a complaint from the hospital perspective. That sometimes the doctor...
the satisfaction
Yes.
or the
Yes.
complaints
Yeah.
about that. Yes, absolutely. And I think that's one of those that, if you think about one skill of reflective listening, that it can be used as a summary. And that is one where I think it can be even more helpful when it comes to that perhaps fibromyalgia patient or the type of patient who, if you gave them the space, they would talk to you all day and all night, and you would still be there the next morning, and they still would be going on and on. Sometimes when you offer this as a summary to show that you've heard what's been said, and then you can pivot with a question that moves it, where you're really taking the reins back. You're now leading again. It can show that you've heard what's been said, and then you are pivoting now, moving it in a different direction where it needs to go. And that can sometimes, I think that what we often do when we feel rushed or we're starting to think, oh my gosh, this visit's been going on forever, we've got to cut this off, is that we just immediately jump to that question or to the pivot. We say, okay, so what I'd like to get back to, or I want to make sure that we discuss this. But if we miss that part where we have acknowledged what that person has said, that's where patients can start to get really frustrated, and we can see satisfaction scores going down. So my suggestion would be, even though you're feeling that tension within yourself to pivot and move on right away, offer one little statement that would acknowledge what that person said so far. Whether it's just, you've had a really hard week and a lot's been going on with your family, or if they're rambling about a movie they just saw and they're telling you every detail in it, to say, you really enjoyed that movie you saw this weekend, and it was probably, you thought it should have won in the award, it was so great. Let's move on now. And so notice that all I'm really doing there is I'm using words to really try to capture and make sure that the person knows I heard what's been said, and now we're moving past that. And what that can do from a communication standpoint is that you're not getting that person who feels like, I wanted to tell them one more part of that plot for the movie, or I wanted to tell them one more thing about my fibromyalgia that I read online. And so you're acknowledging what's been said, and then you're taking the control back of that conversation. Because it really is a dance. You're needing to shift from a style where you're listening some, but your job is also that of an expert. And so then your job is to move back to taking control over the conversation and determining where it needs to go.
Point taken. Thank you.
Wonderful. So I thought we could do one more practice doing reflections. If we have two people, this will be one, we'll take it out of the patient type of interaction, and maybe even learn a little more about your colleagues. Would two people be willing to do this, one person as a speaker and one person as a listener?
Yeah.
And you can be a speaker. And
So what do you want? You want a patient?
patient and a doctor.
And a doctor?
We're going to do a doctor and a doctor.
better to have
It's
a
going
woman
to- so the topic here is going to be to just talk about why you decided to go into medicine, or why you decided to go into rheumatology.
No, we need
Doctor.
two people. So Dr. Khalid and who would volunteer with Dr. Khalid?
No,
Dr. Saad.
one of you.
Okay, come, I'll do it.
Okay. I don't have this.
Thank you.
Actually, one patient, female patient, realistic rheumatoid.
You understand?
What are we supposed to say?
Okay.
You're supposed to sit here?
No.
Are we supposed to stand? No, stand will be fine. We are bring this chair.
It would be short. Stand.
Oh, this is very official.
It's beautiful. He has some more than me. No, me and her, we click. Actually, let's take a picture with you. And my voice is loud.
Okay, who's going to be the speaker and who's the listener?
Speaker of the House, Nancy Pelosi.
It's always he's the speaker. Don't stop speaking.
Okay, so the speaker is going to talk about why you chose to go into medicine or why you chose to go into rheumatology. The listener is going to try to keep the conversation going with so this is going to be one of those no questions, just reflective listening statements. So as the speaker, your job is to keep it kind of going along as much as you can. So when you say, oh, I chose to go into medicine because I really love helping people, when the listener
So I'm the-
responds with really
I'm the doctor. No, it's better that I can. I'm the doctor. Oh,
Okay, sorry.
then you would say something back, not just yes or no. Just say a little more so that she can then reflect it.
again. So who's so I'm the doctor explaining to you why I joined medicine and
why you did
but I have this.
Okay, you have the mic.
Okay, and you are the.
I'm listening to you.
You're just listening.
I'm a doctor
Okay,
friend.
okay.
We're on the coffee.
We are in the coffee.
We're having coffee. I was just telling me about your life.
No,
We never have time for this.
we never had
So
actually.
good.
Yeah.
Let's do this.
Alrighty. So I actually joined. I joined medicine because my father made me. Simply.
So your father made
He
you
really
do medicine?
wanted me to be a doctor. And I actually wanted to be a nuclear physicist. And then I changed my mind. I wanted to be a mechanical engineer. But then my father used my friend, who was older than me, and then we actually had to spend 1 week at the university just while I was in my vacation of
That's
school.
really interesting. You wanted to be a nuclear physicist and a mechanical engineer, and you're now a doctor. Very interesting.
Very interesting, actually. So 7 years of medical school with its good, bitter and sweet life, and I never saw my family for a month. Sometimes because I live far away from the university, and is that supposed to happen, right? Like,
Yes, there are so many struggles, right, in medicine, and a lot of sacrifice.
Yes, lack of psychologists as well. So it's a lot of work, a lot of time, and then I graduated, and then I wanted to be an endocrinologist, and then I changed my mind, didn't like it. Every day diabetes, and I'm done with diabetes, so I changed to rheumatology.
It's too sweet for you, diabetes.
Too sweet.
So,
And yeah.
So now you're a rheumatologist. I'm glad. So we're here together.
Yeah. And then I learned, I knew you after that, and I found out before I came from Canada that you're a big star.
It's not about me. We're talking about you now. So, yeah.
Yeah. So that's it. That's my life.
And rheumatology is what you're doing right now, every single day.
Every single day, patients care, administration a little bit, and then, that's it. It's not bad. Life is not bad, huh?
Life is not bad.
No.
I'm so tempted to ask questions here. I've stopped myself so many times from asking
Am I
questions.
supposed to talk for too long? I can talk for tomorrow. I don't mind.
He's a fibromyalgia patient. He actually has fibromyalgia.
We could do this all day long.
So, I mean, I had so many questions, but because you said no questions, I'm like, I want to say, how does that make you feel? How that you were not a physicist, how do you feel about this now? But, I'm really stopping myself asking questions because I'm doing the reflecting.
So I think this practice is really just designed to get you you did an amazing job of keeping that going, and even saying the statements that probably you wanted to offer as a question, like, so you now just do rheumatology all day long, which was getting at, well, maybe he secretly has a secret life as a nuclear physicist. Who knows? But
I wanted him to say how it made him feel, because doing rheumatology all day long, you could be like shooting rockets with Elon Musk or something, but he didn't really go there. So,
Yes, and in normal conversation, of course, we would never just offer reflective listening. That really is intended just to show that really, as a conversational style, you can get a lot of the same information that you can get from asking questions. But of course, in a real kind of exchange, you would put a lot of questions in there to ask, gosh, how did that make you feel to field that you really didn't feel like was your first choice. Or to ask what kind of stuff was hard when you were not seeing your family for a month, or what did you do during that time? All of those things would be reasonable, of course. But thank you for doing that.
Oh, sure. Thank you. Short movie.
Go on now to the next one. That was wonderful.
Amran Khan and Anushka.
So this next one, and these next three are a little bit shorter in terms of the slide, the didactic part. But I thought I couldn't give a talk on behavior change skills without talking about change talk. Is that a term that any of you have heard before? Change talk at all?
No.
Okay. Oh, then this will be a new one. So when we talk about people moving and becoming more motivated to follow the treatment plan that you have given, one of the things that seems to predict outcomes very strongly is what type of speech that patient uses. And when we think about change talk, we listen to it all the time in our interactions with our family and friends. If I was asking my husband to pick up the dry cleaning on the way home, and he said, if I get out of clinic early enough, I'll try to do that. If I was planning on wearing that dress the next day, I probably shouldn't plan my whole wardrobe around it if he's giving me messages like, I'll try, or I'll see, well, I'm pretty busy, I'm not sure. Those kind of statements are indicating that somebody is not, they're not really giving me that full level of commitment that I would hope to get. And that's an example in the real world of what change talk sounds like. Change talk, as a definition, is any patient's speech that fosters movement in the direction of change. So it can sound like desire. It can be, I really want to follow this treatment plan, or I wish I could do a better job taking my medication. It can be about ability. So it could be, I'm able to stick with a plan once I understand it, or I would be able to do this. I think I could do this. It could be about the reasons. I'm so sick of being in pain that I'll do anything, or everything else hasn't worked for me. If you're saying that this will actually help me, that's a good reason for me to do this. Or it could be about need. I really need something to be different in my life. So if we think about those categories of desire or ability, reasons, and need, and we can categorize talk that falls into those categories, we can begin to think about that person moving, if we think of a fork in the road, that they're moving in that direction of change if they're giving us that kind of language. And so that language, we would want that to be linked to that specific behavior change goal. So someone talking about medication adherence, we would want them to be saying something like, I'm committed to taking this every day, or I will take this every day. It would be very different if an off-topic change statement would be, I want to eat a healthier diet. It's not directly linked to that behavior change goal. So if we were talking about adherence, we would want all the talk to be around what are they going to do to make sure they take this medication every day, or know what needs to happen to make sure that they have their own internal arguments for that change. These are so sometimes originally what we thought was, well, we just have to sit back and wait for somebody to become motivated, to start talking themselves into change. Now what we know is that we can ask specific types of questions. So here's where these questions can come in and be even more powerful evocative questions, evocative being ones that are drawing out this type of change talk from the patient. And we can get them to start expressing this kind of talk. And we know that the more frequency, the more time this person spends talking about change and giving us change talk, the more likely they are to commit to that goal and to follow through with that, that we see that the change tends to follow that. So here are some sample open questions that evoke that talk in favor of change. How important is it to you? This gets at their own need to do this. Is this something that they're really viewing as something that is important to them? What might be some advantages of sticking to this treatment plan? So notice that here, the question that we tend to ask is, what's going to get in the way, or why can't you do this, which tend to go down more of that negative path. But if we instead ask, what might be some good things about sticking to this? Now the person might say, well, if it works the way I hope it will, I might be in less pain. I might be able to get back to gardening. I might be able to spend more time playing with my grandkids on the floor. And then in their mind, what that's doing is it's really shifting that that thought process where now they're thinking, they're connecting these dots, that if I take this medication as prescribed, this could potentially be the outcome that I really want. Another one, how would you like for things to change? How would you like them to be different? So this could be if somebody comes back in and they're telling you that they missed half of the doses of the daily dosing, they took about half over the last few weeks. How would you like this to be different moving forward? Again, they're starting to express and motivate themselves by what they respond to that. Somebody who's struggling with adherence, another question can be, of these options you've considered, what seems the most possible? If they've started to say, well, maybe I could put it next to my toothbrush, or maybe I could start to take it every night before I go to bed. Maybe I could carry it around in my purse. You're directing them and having them start to envision what that would look like. So what do you think about this? What kind of questions could you think of that might evoke change talk? Any thoughts?
All the questions out there. All the questions are on the screen already. Yeah.
That's it. Well, that makes it too easy, doesn't it?
Yeah.
So I thought we could do another activity. If we can have 2 more people volunteer to do this. See, now I'm taking those quotes off of there. Now you need to be on their own.
Now about that.
So what is it, sorry?
I missed the last part.
This is a new session or somebody is talking with us with the...
No, you're saying what change.
So then get somebody else on the next one.
Okay, Dr. Jamal? Sorry.
You can do it.
Change topic, 2 ladies.
2 ladies changing topic. Elegant.
Oh my God. Women power, come on.
Empower women. Yes.
Can I be the patient for a change? I'm tired of being a doctor listening.
So what shall I start asking you about then?
Okay, I'm the patient, you're the doctor.
Okay, so the speaker, so the patient is going to start by saying, I don't like taking this medication every day, but I do want to feel better. Sound familiar?
Exactly.
And then the listener, the doctor, is going to try to keep the conversation focused on the change side of the argument. So notice that in that first statement, you could go either way. It's, I don't want to take this medication every day. And then there's also the, I do want to feel better.
Okay.
So try to focus on that change part of the statement,
Okay.
and then ask some questions around that. So you could just ask, what would be some good things about being better? Or what would be some good things about feeling better? And then try to keep that conversation going in that positive direction to get them to talk more about that rather than focusing on the, I don't like taking medication every day.
Doctor, I'm really tired of being in pain. I do want to feel better, but I can't imagine taking these medicines every day for the rest of my life. Please learn from all the patients.
The pain in your voice.
Okay. Any idea in mind how you can be better without taking the medications?
I'm sure I've heard so much about, diet changes, and I've heard about, and I've read on Google that people have actually cured their arthritis just by eating the right kind of food. So just give me some diet advice. I don't really want to take medication for the rest of my life.
Such a hard patient.
Imagine what we go through.
It's not a bad idea at all. I think diet modification will play an important role, but any other suggestions in regards of medications?
Well, I need suggestions from you, doctor. I just don't want medication.
You know, my
Very
She's a
difficult
hard
patient. I am, but half of mine are like this. So
Well,
I'm getting a chance.
in regards of my advice to medications, you know, it's going to be, I want you to express your feeling toward the medication, how we can make it better.
Well, is that the only way out?
What
There's
sorts
nothing
of
else.
change in your life that might make you feel better?
Well,
toward
just
your
being pain-free.
medications?
Just being pain-free. I want to be pain-free, but not really want to take medication. I'm happy to do any kind of, exercise you advise me, or you advise me on diet that I can follow and, be pain-free.
What make it really hard about medications?
I think it's just the fear of being, victim to all these side effects that I hear about. It's all, at the end of the day, chemicals going in my body. And I'm really scared of the side effects, what impact it may have on my life long term.
Okay, do you think that the impact of the disease might be less than the medication? What do you think about that?
No, definitely not. I'm sure if the medicines are being prescribed to so many patients, I'm sure they do a lot more good than having the disease itself. But I'm just trying to explore if there are other ways of, managing the disease.
Is it about the particular medication you are taking?
Any medicine long term, any medicine that we need to take on a daily basis for a long term, that makes me afraid.
I want to help you, but you have to help me as well. Any suggestions?
But I know this can go on. She did. She really did well. She did really well.
Yeah, that deserves a round of applause. It was
Thank you.
so
I just tried to be as difficult.
You just stayed with it and you were calm about keeping it going in that direction. And I think sometimes that persistency is what it takes. That you're choosing not to go down that rabbit hole with those patients.
But that's classic.
All right, so I want to go through just a little bit on Teach Back. This is another one that I think that the way that we can share information with patients, the smaller bits that we can provide, and such a big part of your role, of course, is to educate patients. But doing it in this style seems to help with adherence because people really understand what needs to be done, especially when things seem that they're really struggling with complex information, maybe dosing, understanding what has to be, the way that the medication has to be taken. The simple strategy for information exchange is to elicit. So first you ask this open question to draw out what the person already knows, and then that way you're able to understand where they're starting from. You then provide the information in very simple language, maybe focusing on 3 bullet points maximum, and then you pause to do this second elicit, which is really the difference in how, in the information exchange process, where you ask what we really consider a teach-back question. So notice that there's the elicit provide, and that second elicit is a teach-back question. So you ask the person not just, do you have any questions, or even what questions do you have about that, but you ask them to restate it in their own words. And so you would just say, okay, so now I want to make sure I did a good job explaining that. What's your understanding of how this medication needs to be taken? And then from there, you evaluate their understanding. And if they don't seem to be getting it, you go back to the provide. And so what this does is it allows you to build on the information that you're providing in a sequential way, so that you can make sure that that initial information that was given is understood before you move on to the next part of the information. And this really seems to help with adherence that's resulting from somebody from misunderstanding the information. So in this one, I thought we could do a little scenario of Mary Ann, who's a 38-year-old patient with RA, and she's been responding pretty well to things, but suddenly it seems that she's not understanding how this medication needs to be taken. She is saying, well, now that I've had such good results, I think what I'll start doing is just taking this every day as kind of a PRN medication. I'm not going to take it when I'm experiencing pain. So how could you use that elicit, provide elicit, to educate her to make sure she understands the way that this needs to reach a certain level in the body and really stay there, rather than you just taking it the way that you would take Tylenol or ibuprofen. So who's willing to do this one?
We have Dr. Mustafa and Dr. Jamal.
Dr. Jamal and Dr. Mustafa. We don't have more HCPs.
Okay. Just
This
because
is a
of time,
patient.
I will just rush it. I will do it myself.
Patient
You're the
case.
patient now, Alyssa.
So Alisa, you will do the patient?
You'll do the patient. Yeah. Put you on the spot. No.
Okay. So
No.
I'll say, I think I'm doing really great. I feel good. My joints feel better. And that medication is kind of expensive. So I think what I'll do now is I have that dose you gave, the last refill you gave me. I'm going to just take it when I'm in pain, and that way it will last longer. So I think that will work.
Well, Lisa, I'm happy that you're feeling well and fine, and we are all for that target, but I want to maintain that you're being fine and well. So the medication you're taking is not targeting pain, it's targeting inflammation all over. It's like we're trying to suppress your inflammation in your body over a long time. So whatever decision you're going to take, we have to be partner in it, and we're going to do it in partnership. So if you'd like to reduce your medication, let's check first your activity, and then we'll take it gradually, and we'll do it together to start with. But I don't advise you to do that, because you're going to rebound with activity that's going to cost you more at the end of the day, since the cost is an issue for you.
So you mean that if I take if I just take it as needed, then there's not enough in my body to fight the
It's more than that, Lisa, because it might go further, that the medication you're taking now won't work for the future, and we have to reinvent the cycle again, go again to another medication, which is unknown you're going to respond to or not.
Oh, I don't want that.
Fair enough. So let's stick together
Fair
and
enough.
work.
All right. Give me that dose.
Take care.
Excellent.
Bye.
Thank you for doing that one. So now the last one that I want to talk about is routine formation. And this is one that some of you know about, the Care Coach program that's offered. This is something that I work with the care coaches to build this into, actually all of these in, but this is one especially where they have a lot of the extra time to help the person with routine formation, and we know that this is another really critical skill when it comes to medication adherence. So habits are just choices that we make at some point, but then we stop thinking about, but we continue doing. And the current estimate is that about 50% of what we do during the day is actually habit, that we somehow have just activated the part of our brain that, such as drive, when we're driving, that we don't have to use all the cognitive resources that we would normally have to do, perhaps when we first started driving. But now we can do all those things in a pretty automatic way. And this is why sometimes when we're driving to work, we don't even know what street we went on. We just kind of went on autopilot. And that's what habits are. So the routine, in this case, when we're talking about medication, the routine of taking the medication falls between that cue and the reward. And so we know everything has a cue, which is something to get it started. And a reward initially that helps the brain understand that this is something that we want it to learn. So if we were wanting to brush our teeth more, then the cue might be that we, this is actually what happened with toothpaste companies, where the cue that they tried to start marketing was that when you have that filmy, that kind of slimy feeling on your teeth, that is when you should want to start brushing your teeth. And then the reward of that is putting all that minty smell and the flavoring in and it foaming, that your mouth likes that. You feel that clean feeling, even though the slimy stuff really comes back automatically very quickly. But that was the habit loop that the toothpaste companies really adhered to. So the first step of this, of finding a routine, is to understand what that trigger is. What is it that gets it started? So that could be what time they take the medication, what their morning routine is, who is around them. It could be a loved one, or having stacking those habits so that there are other habits that they might connect that to, such as toothbrushing. And the more triggers that the person can have, the better, because that means that contextually there's more to get that started. And then the second step is to identify the reward. So this should be something small that, as you're trying to form a routine, that you add to the end. So it could be, some people give themselves a warm cup of tea, or some people enjoy playing a game on their phone or scrolling their social media, whatever that is. But there's something that you want to do to be intentional about this, to add that reward in, because it's connecting that in the brain and making it something that's more reinforcing. And then to verbalize that as a plan. So you would say, when, and then insert that cue. So when I wake up to brush my teeth in the morning, and as soon as I finish brushing my teeth, I will take my dose, because it provides me with, maybe it's there's a mouthwash that they like using, and so they insert it in between those two, so that to get to the mouthwash they like, they have already taken that dose. So this last one, I thought that we could just briefly talk about, and we can do this as a group, talk about the triggers or those cues and rewards that might work for you if you were prescribed Rinvoq. What would be something that might, if you were having to incorporate this into your daily routine, what's something you could use as a cue, and what's something you could use as a reward? Any thoughts?
Well, I'll take this. When I finish work, I will take my dose because it provides me with energy to go to the gym, for example. Just a quick one.
Excellent.
Any thoughts? Plan and reward, habit and reward.
Running out of battery.
You have a plan in form of reward. I will take my dose because it provides me لازم رينفوك ها الله اكبر عليكم.
مش لازم. لا, any oral medication, daily medication.
Yeah, it could be any oral one.
Any oral medication. Your vitamin.
Go short.
I would reward myself.
You're right.
home chores.
Habit formation.
Shopping.
You can't shop every day. If you have to take a
Shopping!
If I'm thinking for a week,
But
a
I
full
want
week.
myself shopping once a week.
No, but every day
I
you
like
need a
that.
cue and a reward.
So it doesn't need to be a reward in the same day.
Doesn't have to be a reward in the same day. I'll accumulate all my rewards.
Yes,
And
I like that works too.
So, we could say something that every day when I finish work, I'll take my dose because then I'll give myself a star, and when I accumulate enough stars, I'll go shopping once a week.
Yes. Absolutely.
Any other thoughts?
It would be nice. I like this.
Anyone else?
I like this method. I
Miriam?
never tried it before. Actually, I never thought of it.
So-
you tried. It's like psychology.
Khalid, I can suggest something on your behalf. If your patient taking their medication with no break in a week, you're gonna be on your social media.
He's going to quit social media.
I'll be destroying my career by confidentiality breakage.
He'll quit Instagram.
Well, that's interesting. It's linking what the patient likes, and of course, it's playing psychology, but at the same time, playing it realistically. They are unable to do a certain thing because of the rheumatoid. Then you link taking the drug with that thing. I like that method.
And automatically will become an addict after that.
I think one of the
And I think the thing that you really want to link it to is the thing that's within their control, because you don't want it to ever be about the efficacy of the medicine, because you can't, that's not within their control. That has a lot to do with how their body responds to that. But of course, the thing that they do have control over is taking it as prescribed. And so the more it can be linked to the actual taking of it rather than I'm eventually going to be able to run a 5K or garden again or whatever their goal is.
Well, I think the best example I can think of as a mother, like I'm having cervical radiculopathy for the last 2 weeks and it's affecting my life, and it hurt me that I can't look after my little kids. So probably, if you correlate it to the family life and something that's really touchy to the patients, you can encourage patients to take the medications in time. Yeah.
Absolutely. Yeah, I think that really that's a perfect segue into just this summary slide of, we know adherence improves when people have their own why. The more that they can connect this to the things that are important to them, that intrinsic motivation. And when you, as the providers, can recognize that value of listening and balancing that with the other skills of directing the conversation and educating, when there's that curiosity and interest about that person's journey, but specifically that you're really going after the change talk and trying to understand their reasons for change, and using the person's own wisdom and insight, that in that demonstration that we did of evoking the change talk, that it can be really easy for us to feel like we have to own this person's experience and solve it for them. But instead, sitting back and saying, this is really up to you. What do you see as the value in this? And understanding, getting them to build their own motivation, not us doing all the heavy lifting. So evoking their own motivation for change. And then being a little more restrained in how we provide information, knowing that sometimes patients aren't keeping up with how much information that we're providing to them. Those are really the key skills. So I'll stop there. I know we're close to the end, but I think if we have any last questions, I'd love to answer anything about what we've gone over today.
Well, thank you very much. I have a question for you, Elisa. Just, is there a tool you know of that you can screen those who's wearing a mask when they come to the clinic? They don't show you the picture that if they're compliant or not. Is there a tool people can use in clinical practice which a good validity kind of predictivity saying this is a compliant or not? I mean,
Gosh, I wish. I think really it has to do with the more we can get the patient to open up and talk about the what it's kind of weeding through the
Between the lines, yeah, gotcha.
the mask,
Yeah.
getting past that. So I think the best practice is to believe them when they first say, "Oh yeah, I'm doing this," or I'll take it, no problem. When you see them again, and it seems like they're not following through with that, or the labs don't indicate that they're taking it as prescribed, to then say and pose that as a, I'm confused here, or I'm not sure what you want to do moving forward. You're saying you really are committed to this, and then on the other side, you're also, it doesn't look like you're following through with this. So what are your thoughts about this? I think having that kind of conversation where you're really presenting that to them as ultimately this is your choice, because I think the more you can empower the person to do the heavy lifting so that you're not the one getting so caught up in feeling like, now I'm worried about this person, now what can I do? The reality is that you can't go home with them and give them their dose every day and make sure that they take it. They have to be accountable for that kind of stuff on their own. And so it's easier on you, and it's easier really to make sure that they understand that ultimately you're there to support them, and it's really up to them to follow through with it and figure out what's needed to make that happen. But there's not a good mask removal tool of saying what.
Okay.
Who are the people who are not doing it, other than listening to whether they're giving you talk that doesn't seem like it's real. It's
let me start where you stop.
Like
listening. It's expensive in our practice. It costs us money between patients. So now, assigning somebody else to do the listening and communicate like a assistant or etc. for educational or patient allied, would that help? Yes. And if you've seen it in practice, does it help or not?
Oh yeah, I think one example of this is the Care Coach program, just with having somebody who can do a lot of that, the work of listening in that way, but also nurses, other assistants, other people in the office who have an ability to spend that extra time and work on maybe some of these skills like the habit formation or the asking those change talk questions to get the person to move in that direction. All of those things are known to be the science-based ways to help improve adherence.
Appreciate it. Thank you.
Yes, of course. Thank you.
Another question? I think we're done. Thank you, Alisa, for your time.
Thank you very much.
And thanks for the audience.
Thank you all so much.
Thank you, Alisa, again for making it at the middle of the night.
It's morning now.
Now I'm caffeinated and ready to go.
Thank you. Thank you for bed.
All right.
Thank you. Bye.
Goodbye, everyone.
Bye.
This was nice.
عجبتني الريفلكتيف listening.